हेलो फ्रेंड्स, वेरी गुड आफ्टरनून टू ऑल ऑफ यू। कैसे हैं आप सब? एज वी ऑल नो दैट वी आर अप्रोचिंग टुवर्ड्स अवर एग्जाम्स एंड आई एम वेरी श्योर that each one of you had made some strategy how to study, for how many hours you have to study, how many hours you have to give any subject, and you must be preparing according to your strategies. As we all know that making a strategy and the good plan, good strategy is very important, but the most important is that you have to stick on your strategy. You have to do the proper execution of your strategies, and that will be your secret or success mantra for your exams. So whatever the strategy you had made, you have to execute it honestly, completely. Then only you will be able to achieve your goal. So we are here to revise the PSM, and we had discussed a few topics in our previous class. Now we'll be coming with a few more topics, and the next topic of discussion is international health. The point to remember in the international health is the quarantine and isolation difference. The separation of the apparently healthy person for maximum incubation period of the disease is quarantine, while the separation of the diseased people who had been diagnosed with the disease till the period of infectivity is your isolation. The India follows the quarantine for the two diseases, the yellow fever. The quarantine period is 6 days. No confusion from the incubation period, it is the 2 to 6 days. The COVID 19, the quarantine period is 14 days and the incubation period is 2 to 14 days. Now, if we talk about the yellow fever vaccination certification validity, it starts 10 days after getting the vaccination and it lasts lifelong. But nowadays, we have been replacing this quarantine with active surveillance. Now, at the same time, to prevent the entry of the yellow fever in India, we have to do the mosquito control, regular spraying of an insecticidal agents, because Aedes mosquito, which is the causative mosquito for yellow fever, it is breeding in artificial water collection. So we have to avoid the artificial water collection, and its fly range is only the 100 meter. So we have to keep the 400-meter radius free from the mosquito breeding places, means no artificial water collection should be there. And we have to keep the Aedes aegypti index to less than 1%. And what it is the number of the breeding sites per 100 houses examined. Now, there are the certain diseases for which we have to inform to WHO within 24 hours that what preventive measures we are taking so to avoid the epidemic conversion. And these diseases are yellow fever, cholera, and plague. Now, there is a threat of bioterrorism, and the organisms are classified into the three categories. The category A, they are causing the high mortality. The B is high morbidity and they are difficult to diagnose. And the category C is high mortality, but they are the new upcoming agents like coronavirus, Nipah, and the Hunter virus. Then, if we talk about the category A bioterrorism agent, the most commonly used is the anthrax. The second most commonly used is the plague, and the botulism toxin is most lethal toxin among the other toxins, like as a diphtheria toxin, tetanus toxin, and botulism toxin. These are the three toxins which are causing the problem, and botulism is the most lethal toxin. And we can have the category A bioterrorism by smallpox, tularemia, or the viral hemorrhagic fever also. The category B bioterrorism is because of brucellosis, Q fever, epidemic typhus, Clostridium perfringens, viral hepatitis, and streptococcal enterotoxin B. Then there are the certain international agencies, and one of them is the WHO, World Health Organization. Its head office is in Geneva, and as this was started in 1948 on 7th of April, so the 7th April is celebrated as WHO Day. Every year we are releasing, or the WHO is releasing a theme, and theme for 2021 is the time to build a fairer, healthier world for everyone, everywhere. Then another agency for the children, that is United Nations Children Fund, with the head office in the New York, USA, and its function is mainly for the children as well as their mothers, the Go by FFF activity, the growth monitoring, ORS, breastfeeding, immunization, and the female education, food, and fertility control. The other agencies are the Food and Agriculture Organization with the head office in Rome, Italy, International Labour Organization with the head office in Geneva, Switzerland. These are the logos of, this is the logo of the WHO, this is the logo of Food and Agriculture Organization, and this is the logo of UNICEF with the logo of ILO, International Labour Organization. Then a few points about occupational health. Now, we all know that before taking any worker for the job, we are doing their health checkup. So that is the ergonomics, the pre-placement checkup. So the right person gets the right job, and obviously this is your primary level prevention. And in the primary, it is specific level prevention. While we are doing the regular health checkup of the workers who are in the industries to look for any underlying problem, and that is your secondary level prevention. So no confusion, ergonomics is pre-placement checkup, so it's a primary specific, while the regular health checkup is secondary level prevention. Now we are having the two very important acts, the Factory Act and the ESI Act. The Factory Act says that space per worker should be 500 or more cubic feet per person. There must be the one safety officer per 1,000 worker. One canteen should be per 250 workers, and there should be the facility for the one crutch if a worker female is 30 or more. Then age is very important, that child less than 14 years is not permitted. The child between the 15 to 18 years can work in the industry with a medical fitness certification, and if it is more than 18 years, धक्का मार के भेजेंगे भाई काम करो. The working hours are maximum with the 48 hours per week, on an average is 8 to 9 hours per day, and with overtime, if you're giving a lollipop of overtime, still you cannot make them to work for more than 60 hours per week. We had an ESI Act and the corporation, that is Employee State Insurance Corporation, and as per the guidelines, they say that the facilities to be provided to the worker as well as to their family members. And the Union Labour Minister is the chairman of the ASI Corporation with the head office of the Central Labour Institute in Mumbai. And the areas which are not included under the ESI Act is railway, defence and the minings. So railway, defense and the mining are not covered under this because they had their separate medical facilities giving institutions. And here the worker has to contribute. And this is very important. The contribution of an employee is 0.75%. The employer is the 3.25%. Employee means the knocker. Employer is the malik. And if it is a private institution, then the employer has to contribute, and some contribution is by the government, and that is a major chunk up to the 96%, and share of the state to central is 1:7, or 1/8 is by the state and the 7/8 by the central government. And the workers who are getting the salary up to the 21,000 rupees per month, they are entitled for this benefit, and those who are having the salary beyond that, obviously they can pay because they had a for the services, medical services, because they are earning quite good, so they are not getting the benefit under the ESI Act. So what the benefits we are giving to the worker and their family, that free OPD and the IPD care to the workers and their families, and the leaves are very, very important, commonly asked in the examination. The 91 days or the 3 months of the sickness leave with 70% of the salary, the extended sickness leave for 2 years with 80% of the salary, and the 6 months or the 26 weeks of the maternity leave with 100% of the salary. Then if a person is having some disability while on duty, it is a temporary disability till recovery, the 90% of the salary, and if it is permanent, then pension is started. The workers are exposed to a group of the diseases, and one of them, the most important, is the pneumoconiosis, because they are inhaling the content and it is causing the problems in the lungs and alveoli. So the particles which are less than 5 micron size, they can pass through the filter mechanism and they can reach up to the alveoli. So it is said that the most dangerous particle size is 0.5 to 3 micron. So we have to see the option very carefully. If it is asked like a less than 5 micron, 5 to 10, 10 to 15, more than 15, then we can go with the less than 5. But correct option is 0.5 to 3 micron size. Now this is the size of the particle, the dust, which is causing the pneumoconiosis. So this is a pneumoconiotic dust particle size is. The dangerous particle size is the insoluble because they are not being removed by the blood circulation. Then the diseases which can be seen in the workers is the most common is silicosis, and it is because of the silica particles, and it is seen on X-ray as a snowstorm appearance, while asbestosis is because of the asbestos particles, and this is the only pneumoconiosis which is causing lung carcinoma. Okay, and anthracosis is because of the coal particles having the possibility of the progressive massive fibrosis even after removing the person from the environment, and the longest incubation period is around 10 to 12 years. Now one more point about the silicosis, that silicosis are prone for tuberculosis, so we have to do their follow-up for tuberculosis. The bagasosis is because of the sugar cane bagasse, and Bastonosis is because of the cotton fibers, and farmer's lung is because of the moldy hay or the grain dust. Now, the bagasosis and the farmer's lung, it is because of the fungal growth. So, the fungus which is responsible for the bagasosis is the Thermoactinomyces saccharii, which can be prevented by sprinkling this bagasse with 2% propionic acid, and this is a non-notifiable disease. While the bastonosis, it is more commonly seen in the textile industry, especially in the workers who are concerned with the spinning department, means they are making the yarn from the cotton, they are spinning the cotton. The farmer's lung is because of a fungus that is Micropolyspora feni. Now, as I said, that most common occupational cancers are the skin cancers that are responsible for three-fourths of all of the occupational cancers, and the only pneumoconiosis which is causing the cancer in the lung, it is the asbestosis. And the most common carcinoma in the lung because of the asbestosis, the bronchogenic carcinoma of the lung, but the most specific is mesothelioma of the pleura. Now we can have the lead poisoning also in these workers, and this is commonly seen in the workers who are working in the lead industries or the battery industries because it is containing a lead. And the most common route of entry is through the inhalation, but it can be through the food stuff, like we had the high lead content in the Maggie few years back. So all the food stuff has to be undergone through the testing, and they should have the certification, or it can be through the water also, or it can be absorbed through the skin, but the most common is the inhalation. Now when serum lead concentration is reaching beyond 70 microgram per 100 ml, then it can cause a clinical manifestation of the lead poisoning, and before reaching to this level we can detect some lead metabolites in the urine as the urinary coproporphyrin, and if the level is more than 150 microgram per liter of the urine, it is suggestive, or it is giving us an idea that person is being exposed to the lead for some time, and we can remove the person from that area. So urinary testing is as a screening test. The clinical features what we can have because of the inorganic lead compounds are the peripheral symptoms, and there is blue line on the gums as the Bertonian line, and the facial pallor. We can have the stippling in the RBCs, which is of the basophilic staining. So basophilic stippling in the RBCs can be a wrist drop or a foot drop. And with the organic lead compounds, we can have the central nervous system manifestations like insomnia, headache, mental confusion, and the delirium. And to treat, we are giving some chelating agents. Now we are having the new activity where we are changing the bed sheet in the ESI hospitals daily on the basis of the color of the rainbow like in web gear, and this is Abhiyan Indradhanush. So no confusion between the Mission Indradhanush and the Abhiyan Indradhanush. Mission Indradhanush is related to the vaccination where we were vaccinating our children for the 7 killer diseases, and Abhiyan Indradhanush is a change of the bed sheet as per the 7 colors of the rainbow, means that daily we have to change the bed sheet. Otherwise, commonly we are using the white color bed bed sheets, and it is very difficult to differentiate whether the staff has changed, because the changed bed sheet is also the white bed sheet. So now they had a fixed color as per the color of a rainbow. Now there is another yojana or the program which is saving the workers if there is an accidental closure of an industry. So this is a Rajiv Gandhi Shramik Kalyan Yojana. So if there is an accidental closure of the a factory, we are giving them the unemployed allowance, and this is given for maximum 1 year with 50% of the salary. So these were all about your occupational health. Then we are having a few points about the social and the mental health, and where we should be knowing about the criterias of the mental health as an IQ. So when we can say the person is having the mental retardation, if the IQ level is less than a 70, then mild if your IQ is between 50 to 69, moderate 35 to 49, severe 21 to 34, 20 or less is the profound. Now how to remember? Now you can see that 70 is a cutoff, and next is the 20. So you can remember like a 50 to 70 also, and after that we had a group of 15, like a 35 to 50. You can remember just 35 to 50, 21 to 35, and 20 or less, like that. Okay, so first group is 20, then a group of 15. You can remember like this. Now we can have another classification as per the Wechsler scale, and here again the till 70 we consider as a borderline normal. So ideal normal is 90 to 109, below normal is 80 to 89, borderline is 70 to 79. If it is less than 70, then obviously it is having some problem. And we can remember like in IIM, let's say Indian Institute of Management is like that. So here the first group is of the 20, as we had discussed in the mental retardation also, 50 to 69. Then the next groups are of a 25 each. This is the difference from the mental retardation. So it is 25 to 49 or 29 to 50, 25 to 50, you can remember like that, and less than 25 is the idiot. Then what are the criteria for the below poverty line? Below poverty line means the people are living below the poverty, so the government is supporting them. Okay, so criteria is the one is the caloric affordability, not the caloric intake. The affordability by the family, if it is less than 2400 kilocalories per day in the rural areas and the less than 2100 kilocalories in the urban areas, they are considered as below a poverty line families. Or if we talk about the per capita income as per the Rangarajan Committee 2014, and they say that if the per capita income is less than 32 rupees per person per day in the rural areas and the less than 47 rupees per person per day in the urban areas, they are considered as BPL families. And overall, if we say that on record paper, the around 29% families of India are the BPL families. Now, exactly what is the situation? We don't know, but on record, it is 29%, because many of the families, they get their BPL card made for getting the benefits under the various schemes. Now, another important is we are having the modified Kupaswamy scale. This is to classify the families in the urban areas based on their socio-economic status. And the parameters included are the education of the head of the family, occupation of the head of the family, and the income per capita. The total score comes to 29. Now, if the score is between 26 to 29, it's an upper class family. 16 to 25 is an upper middle. 11 to 15 is a lower middle. Don't consider as a railway berth. And this is 5 to 10 is a upper lower, and less than 5 it is a lower category. Then in the education as well as in the business, there is a mixing of the culture, and that is called as the acculturation. Then there is a provision of free medical services by the government, that is state medicine. But if it is being regulated by the social experts, not the local experts of that area, it is socialized medicine. Then what is attitude? Attitude is acquired character through the learning. And once we acquire a character, that remains permanent with us and we behave like that. then उसका attitude बड़ा खड़ है, बिल्कुल ढंग से बात नहीं करता, बड़ा attitude, rude attitude है. So attitude we are acquiring through the learning, repeatedly doing learning, and this is almost becoming a permanent. But yes, we can change the attitude with a great difficulty with motivation also. Now, another point is that what is habit? Now, habit is again, it is through the repetition we develop a habit. Like we tell to a child that wash hands before eating. So every time the mother tell a child that you have to wash your hand before eating, and it becomes an habit, and the child will be doing this forever. That always washing the hands before doing. So this is your habit. So these are the important points about social and mental health. Then we talk about the health education, because the many government policies are being made, but their proper utilization is not happening, because proper communication and the education is not being passed to community. So we are having the channel of communication, where we are having the sender who is sending the message to a channel, going to the receiver, and finally we are getting the feedback. And this feedback is very important, because this help us in improving the information what we are sending to the community. And we are having the two types of the communication system, based on whether this is a unidirectional or the bidirectional. The unidirectional means only the message is coming, we don't know that what is the response of the community. And this is didactic. Now, no confusion, not a die means two. It is, you can remember as a D for dictator. Dictator bolta hai, sunta nahi hai. So only the message is coming, like a method as the television, radio, newspaper, lectures, flip charts, and the flannel graphs, posters. Only the message is coming. It is up to us whether we want to receive that message or not. But a two-way communication is the Socratic method, where we can have the interaction, or we can get the feedback simultaneously. So obviously the Socratic methods are better over the didactic methods, like a group discussion, demonstration, panel discussion, clinical symposium, workshops, conferences, and a seminar. Now, based on the number of the individuals involved, obviously the individual is best among all. But if you want to spread the message within a quick time with a cheaper cost, then we can go with the mass methods of education. And in India, the television is supposed to be the best mass method of education. Now, if we talk about the few group methods that are commonly asked in the examination, that lecture is a one-way didactic, and here the one person is giving a lecture in front of the audience, and this number of the audience can be anyone, and the lecture can be given to the 5 to 10 individuals also. It can be given in a huge auditorium covering the 1,000 individuals or more also. Then flannel graph, or before that, you can say one more point in the lectures, but now we are having the question answer sessions in the end of the lecture. So it is being tried to make a two directional, but theoretically, if a question is asked, the lecture is a one way or the two way, it is the one way method of communication. Now, flannel graph means here the photographs are pasted in a chronological order on a piece of cloth to tell the story or the complete life cycle of that process. The flip charts are again the charts were raised in between the talk when we don't have the this multimedia or the technology where we can have the slides or the posters. The group discussion is again very important, and the question to ask is that what is an advantage, that this is a best method to change the health attitude and the behavior. And a very good example is the promotion of the hospital delivery, and this is being communicated by ASHA workers. And the graphical representation of this discussion is known as sociogram. The demonstration is that we have to tell them that how to prepare a thing like an ORS preparation, or preparing a glass slide, or this smear, or staining a smear, or how to examine a slide, how to take a blood pressure. All we have to demonstrate them. And here only we are learning by doing, or learning what our eyes are see, only our brain can understand. Now, what is the difference in the panel discussion and the clinical symposium? In both, the 4 to 8 panelists or the experts are there. But in the panel discussion, there is continuous interaction among the experts, also panelists, and the continuous interaction with the audience also. There is no prepared talk, no order of the discussion. It can go in any direction. While in the clinical symposium, the individual person or individual expert is delivering the lecture which is already prepared in a particular sequence, and there is no interaction among the experts or the speakers also, and there is no interaction between the talk with the audience also. In the end, the audience is given time to ask the question. Okay. Then counseling, obviously we have to convince them, we have to tell all the advantages and disadvantages of the procedure or the content, and final decision is theirs. And the point to remember is that couple counseling is done in contraceptive, it is the gather approach of counseling, and the family counseling is done in the cancer prognosis, it is the spike approach of the counseling, and the individual counseling is done in the sexually transmitted diseases. Now, the Delphi method is again a group method. Here we are trying to interact with the experts who are sitting in a different places and making a one consensus. This is the image of flannel graph where on the piece of cloth the different photographs are being posted. These are the flip charts are being raised in between. This is again a very important image is the group discussion, and this is asked in the examination, and this is how the lecture is being given, and this is a sociogram, the graphical representation of the group discussion, and this is your panel discussion, and this is a clinical symposium. So these are the few important methods of health education and communication. Now, another important is the health planning and management. Now, here we are supposed to remember the few committees and their recommendations. The first important committee is the board committee. The three committees are very important and asked in the examination: the board committee, Qatar Singh committee, and the Shivastava committee. The board committee has given the concept of the primary health centers, the concept of the social physician, social school health, and the 3 million plan. Then we had the Mudaliar Committee, the All India Health Services, and Chadda Committee says the basic health worker for malaria and the family planning services. Mukherjee says no, we have to separate these workers. And the Jangalwala Committee says that there must be the integration of the health services with no private practice permission. The Qatar Singh Committee is important that has been that they had given a concept of multi-purpose workers and the sub-centers, and they had replaced the basic male health worker by the multi-purpose worker male, and the A&M workers by the multi-purpose worker female. And they had also given the concept of the health assistants at the primary health center. The Shivastava committee has given the concept of the roam. They are not taking you for the holidays at home. They are making you to read throughout your life because you have to keep yourself updated. So reorientation on the medical education, the referral services, and this committee is also known as a group on medical education and support manpower. And there must be the development of the paraprofessionals or the semi-professional workers within the community. We have to train them and take their help, like gram sevak, school teachers, and there must be the village health guide in the village, and there must be the two cadre of the health workers between the community and the doctors, like we had the multi-purpose workers and health assistant. So these are the few important health committees. Then another important point is that earlier we were making the plannings and the policies through the Panchvarshi Yojanas, but since 2014, the Niti Aayog has come in place, and it has started functioning from April 2017. Now, the first meeting of this Niti Aayog was there in month of January 2015, and the chairman of the Niti Aayog is the Prime Minister of the India, and all the chief ministers of the various states, the governors of the union territories, and the experts of the various fields are the members of the Niti Aayog, which are called as a think tank. And they had given the two type of plans. The one was a 3-year plan from the 2017 till 2020, and the another was a 7-year plan from the 2017 till 2024. Now there is a general elections due in 2024, and let us see what will be the fate of this Niti Aayog. The new government will be formed, and God knows what will be the future of this Niti Aayog, whether the new government is going to accept this or they are going to give their own strategy. Let us see. But currently, we have to remember about the Niti Aayog. Then, if we have to implement any new policy, we have to compare this policy with the existing one. So, what are the various health management techniques? The one is cost benefit analysis, because these management techniques are very commonly asked in the examination, because they give you a situation and they ask that what can be the management technique we can use. Now, if we are comparing the input in terms of money, kitna paisa lagaya, and output in terms of the money, kitna paisa mila, like a business, and that is a cost benefit analysis. So input and output in analyze in terms of money. But in the health sector, the output is not always the money. It may be the result. So if our output is analyzed, input is the money, but the output is analyzed in terms of the results. Like if you are giving the money for the vaccine and I'm getting a reduction in the infant mortality rate, then this is your cost effective analysis. Now system analysis is the comparison of a new technique with existing one, and network analysis is we have to make a graphical plan of all the events and the activities to reach to endpoint. And the point to remember is that a critical path method, it is the longest path, and other network analysis is the PERT, program evaluation and review technique. Now, what is work sampling? The questions has been asked in the past two exams from this work sampling. The work sampling means that we have to analyze that how much time is required to perform an activity and what type of activity is being performed. So this is usually done on the doctors, nurses, lab technicians, pharmacists in the hospital, and we have to find out that how many manpower, how many number of the workers or the manpower is required in that particular area. Like take for an example, if we want to decide that how many doctors are required in the ICU. So what we'll do, we'll take a chart of a past 1 month of the admission in that ICU. So if suppose we are having the 5 doctors posted in the ICU and the 20 patients per day were there in the ICU, it means the one doctor was looking for the 4 patients. But suppose next month the number of the patients are decreasing and we are having only the 10 patients in the ICU. So now we can withdraw the 2 doctors from that because the remaining doctors can handle the 10 patients. So like that we have to decide that how many staff members are required for that particular activity. Clear? Then we are having the certain goals given by the United Nations, and these are the MDG, Millennium Developmental Goals, and Sustainable Developmental Goals. So the point to remember, who had given and for what duration, what are the goals, and how many goals are health related. So Millennium Developmental Goals were given by United Nations for 15 years between the 2000 to 2015, and we had 8 goals here, and only the 3 goals, goal number 4, 5, and 6, were directly health related. After 2015, it has been replaced by the Sustainable Developmental Goals because it is actually the continuation, and it was again given for 15 years from the 2016 till 2030. This could be another question, that what is the duration of the Sustainable Developmental Goals? And this was already asked, that who had given the Sustainable Developmental Goals. It has been given by United Nations, and the total goals we had the 17, but the beauty is that only the single goal, goal number 3, is health related. And what is that goal number 3 is that we have to ensure the healthy life and promote the well-being for all at all the age group. And it is being funded by the United Nations Developmental Project. This was another question asked in the last exam, that who is funding the countries to carry out their sustainable developmental goals. It is by the United Nations Developmental Project. And certain targets has been set by the United Nations, that global MMR should be less than 70 per 1 lakh as per the goal number 3.1 by 2030. Neonatal mortality rate should be around 12 per thousand live births, and under 5 mortality rate should be reduced to 25 per thousand live births by 2030. And we have to end the epidemic of HIV, malaria, tuberculosis, and the neglected tropical diseases by 2030, and we have to provide the health coverage to all by 2030. So these were the few targets of the sustainable developmental goals. Now, if we talk about that, what is these words, objectives, targets, and the goals? Now, objective is the plan and point of all activities which are concerned with the problem, and based on the objectives, then we have to decide certain targets. So this is the discrete activity which help in measurement of the achievements of the objectives, and this is concerned with the factors involved in the problem. Okay, and goal is an ultimate endpoint, and there is no time limitations, may or may not be achieved. Now, in a very simple word, if I say that our goal is to clear the FMG examination in the December 2020. This is our goal. And what we had decided, our target is that we have to revise the 4 times before appearing in the examination. And if we are revising the 4 times, then definitely we will be pass our exam. This is the target. Now, for revising 4 times before the exam, then you have to plan that you have to read around the 6 to 8 hours per day, and within 3 days you have to complete your anatomy, within the 3 days you have to complete your physiology, like that you are making an objective. So small objectives you are achieving, and if you are doing like that, then you can do your 4 revisions by the exam, and you can appear your exam, or you can clear your exam, and you can achieve your goal. So objectives are the first, and then the targets, and then the goals. Now if I talk about the health sector, that our goal is, suppose that we want to do the elimination of the measles, and how we can achieve the elimination of the measles if we are vaccinating our more than 90% of the children for the measles, and with the 2 doses of the vaccine. So our target is that we have to vaccinate more than 90% of the children with the 2 doses of the measles vaccine. Now this cannot be achieved in a single year. So what objective we are deciding, that by this year we'll be vaccinating over 80% of the children. By next year 2022 we'll be vaccinating our 82% of the children. By 2025 we'll be vaccinating our 85% of the children, like that we have to decide the objectives, and we have to focus on the objectives to achieve our targets and to achieve our goal. So first is an objective, then the targets, then the goal. Clear? Now, India is also giving time to time the various health policies, and after a gap of 15 years, this policy was released as the National Health Policy in 2017. Before that, it was in 2002, and after a gap of 15 years, it was released in March 2017. Now, as per the policy, it was decided that we had to eliminate the diseases like Kala Azar filariasis by 2027, leprosy by 2018. Now, no confusion. Earlier, we say that we had eliminated the leprosy in 2005, and again, I am writing that we have to eliminate the leprosy here. Now, please listen carefully. Now, in the 2005, our elimination criteria was the overall prevalence of the leprosy, and if our prevalence is less than zero point 0.1 per thousand population, then we say, okay, yes, we had achieved the elimination criteria. But it was seen that in some areas the incidence was high and prevalence was also high. So we had decided that now in each and every district our incidence and prevalence should be below the criteria. And if the incidence is less than 10 per 1 lakh and the prevalence is less than 1 per 10,000 in each district, then we say that we had achieved the elimination of the lepra, or we had achieved the elimination for this disease, and which we are still trying to achieve. So as per the National Health Policy 2017, we had decided that by 17 December the Kala Azar filariasis elimination, by 18 December leprosy elimination, and by 2020 the measles, 2025 is the tuberculosis elimination, okay, and 2030 was the malaria elimination. But we were not able to achieve by these a time, and that's why we say the goal is not time limited. And currently our goal for elimination of the diseases as Kala Azar, filariasis, leprosy is 2020. Now still the new guidelines has not released because of the COVID pandemic, so we have to wait to know the exact status. Then we had a few more criterias, and that total fertility rate should be 2.1 by 2025, and maternal mortality rate should be 100 by 2020. Infant mortality rate will be 28 by 2019, and neonatal mortality rate should be 16 by 2025. So these are the a few important points about your health planning and management. Now, the next topic what we are discussing is prevention in pediatric and obstetric. Very important topic. Many questions has been asked from this section. Now, we all know that if you are giving a good obstetric and the pediatric care, we can reduce our maternal and the pediatric mortalities. So what is maternal mortality? It is actually a ratio. It is a number of the maternal deaths per 1 lakh live births. Very, very important. Remember, it is not a per 100, per 1000. It is per 1 lakh live births, not the total births. 1 point. And if we talk about the numerator and the denominator is the total live births, and it is the multiplying factor 1 lakh. Now, what is maternal death? It's any death which is related to the pregnancy or it is aggravated by the pregnancy, but it is not due to accidental or the incidental causes. And in what periods? The period is right from the conception till the 42 days after the delivery, means antenatal, natal, and the postnatal, all the periods are included. Then, which is the most dangerous period? Is the postnatal period is the most dangerous period, and the hemorrhage is the most common direct cause of the maternal deaths, but anemia underlying is the most common indirect cause of maternal deaths. And the current goal is, as we had seen right now, that bring down the mmr to 100 by 2020, and the sustainable developmental goal says that we have to decrease mmr to 70 by 2030. And we are trying to find out the cause of the maternal death in the home deliveries is by RINE, that is a verbal autopsy. Now, how we are trying to decrease the maternal mortality ratio? If we are giving them the proper antenatal care, visits, and some advices. So here the question is that how many visits we have to give. So read the question very carefully. Average number of the visits are 13 to 14. Minimum number of the visits are 4 as per the Indian guidelines, and the WHO recommends the minimum visit as 8. So please listen carefully that still the Indian government has not accepted the antenatal visit as 8 suggested by a WHO. So currently we are advising the minimum 4 antenatal visits to our pregnant woman. Now TD vaccine, if it is primary gravida, then 2 doses at a gap of minimum 4 weeks. The first as soon as possible, and the last or the second should be preferably 3 weeks before the expected delivery. And if she is multigravida, receive the previous doses within the 3 years, or she had delivered within the previous 3 years, only the single dose is required. But if she has delivered more than 3 years back, then the 2 doses are required. Now we are doing the hemoglobin estimation and the sugar and urine albumin and sugar at the subcenter level to detect the diabetes and preeclampsia, while the group HIV, hepatitis B, and VDRL tests, they are performed at the PSC onwards. So that's why we prefer to deliver a primary gravida at primary health center, because of the blood group availability, and second is the episiotomy repair facilities. The deliveries at the sub-center is being conducted by the multipurpose worker female, while at the PSC it is conducted by the doctor or by health assistant under the supervision of doctor or medical officer. We are giving them the iron folic acid tablets. So here the question is that how many minimum tablets? Minimum 100 in the pregnancy, minimum 100 in the lactation phase. But preferably we are giving as long as patient is lactating, and in the pregnancy it is started from the 4th month onwards till the delivery. And the composition is, please listen carefully, the earlier we were having the 100 milligram of elemental iron, but now the iron tablet is containing 60 milligram of elemental iron. This is to reduce the gastric upset, and 500 microgram of folic acid. Along with this, we are giving them the calcium tablet, and in first trimester we are giving separately the folic acid. And because iron tablets are started from the second trimester onwards, so in the first trimester we're giving a folic acid and only, okay. And we are referring the high risk women to the higher centers. Now if everything is fine, then we can deliver either at the sub-center or we can deliver at the home, and the delivery is being taken place by the multi-purpose worker female with the help of the traditional birth attendant if it is a home delivery, with the use of the disposable delivery kit with the 5 clean techniques like a clean surface, clean hand, and the clean cord, cut, tie, and the stump. And we have to refer the high-risk cases to the higher centers. Now once patient delivers, then still we have to give the postnatal care, and postnatal visits average is 5 to 6, but minimum 3 to 4. If it is a hospital delivery, then 3, and if it is a home delivery, 4. But if a question is asked that how many minimum visits we have to give, it your best answer should be the 3. And here we are looking for any sepsis, like any bleeding, the condition of the baby, motivating for the breastfeeding, and giving them the iron folic acid tablets also. And we are supplementing the vitamin A to the mother in a high dose of 3 lakh international units or 3 ml, because in the baby we are giving vitamin K at 9 months of the age. So till 9 months the baby is receiving the vitamin A through mother breast milk. Now, all the pregnancies are not being converted into the live births. 10% of the roughly pregnancies are being wasted. So, if you know the live births in that area, and if you want to calculate how many will be the total pregnancies, then you have to add the 10% of the um, live births as the wastage in the actual live births. Clear? So, if any time we say that how many pregnancies are reported in an antenatal register, it is always the half of the expected pregnancies. So half of the expected pregnancies are registered at a time, and how many are the expected pregnancies is the total live birth plus 10% of this live birth as a wastage is the expected pregnancies. So this is about your maternal component. Now, if we talk about the pediatric component, our purpose is that we have to reduce the pediatric mortalities. Now, except the stillbirth rate, all mortalities are being expressed as per 1,000 live births. Clear? And as per their duration, under 5 means less than 5 years, the infant means less than 1 year, the neonatal means 0 to 1 month or 28 days, post neonatal between the month to 1 year, the early neonatal is the first 7 days, late neonatal is 7 days to 28 days or 7 days to 1 month, and perinatal is again important. It is from the 28 weeks of the pregnancy onwards during the delivery, as well as the first 7 days after the delivery is the perinatal period. Clear? And stillbirth rate is expressed as a number of the stillborn baby per 1,000 total births, but sometimes we express as a live births also. But our best definition for the stillbirth is number of the stillbirth per 1,000 total deliveries. And a recent SRS survey report has been published, and current IMR of India, as we had discussed, as 32, now it has been reduced to 30. So current IMR of India is around 30 as per the new SRS report. But as I always say that they don't ask exactly the values, because it is changing as per the various studies as per the time. Then how we are preventing the pediatric mortalities? We are giving the vaccinations as per the Mission Indradhanush or VIP program, and we are giving them the breastfeeding. And the purpose of giving the breastfeeding is that we are giving them immunoglobulins, because colostrum is full of immunoglobulins, and mainly the IgA immunoglobulin is there. And breastfeeding to be started as soon as possible, maximum within 1 hour in cases of normal vaginal delivery and 4 hours in the cesarean delivery. An exclusive feed for the 6 months, and supplementary feed is given for 2 years. And if we talk about the differences in the breast and the cow milk, obviously the breast milk is preferred, and if the breast milk is not available, then we can go with the cow milk and preferred over the buffalo milk, because buffalo milk is having very high fat content, very high protein content, and it is difficult to digest by the baby. So preferred is the breast के बाद cow milk prefer किया जाता है. But the difference in the breast and cow milk is that breast milk is having the low of the protein, the low of the fat, and it is having low of sodium, low of calcium, low of phosphorus, and it is high in the breast milk. The it is high in the cow milk. And if we talk about the content which is high in the breast milk, it is the and lactose is high. We are having the high amount of the DHA, the cysteine and taurine is high, and the iron is high. We are having the vitamins are a little bit high, especially the vitamin C is there, while vitamin C is absent in the cow milk. And calcium phosphorus ratio is high in the breast milk. So remember, absolute calcium is low, the absolute phosphorus is low, but calcium phosphorus ratio is high, and that is responsible for absorption of the calcium. Okay, and the good quality protein, the whey protein is high, is 60 to 40 in comparison to the cow milk where it is 20 is to 80 only, and there are very less chances of infection. We are having the first week of August as a breastfeed awareness week, and maximum amount of the breast milk volume is seen up to 6 months. After that, we have to supplement the food. And we had an activity for breastfeeding promotion as mother absolute affection. And the concept of the baby friendly hospital came just to keep the baby by the side of the mother for promotion of breastfeeding. Now we can store the breast milk in our banks also up to 3 months at a storage of less than 0 degree centigrade, and at the room temperature can store up to 6 to 8 hours and 2 to 8 degrees centigrade for 24 hours. Clear? Then we are having the growth monitoring of the baby, and very important worker is the Anganwadi worker in the ICDS centers. They are doing the growth monitoring, and the best indicator is the weight for age, because it is suggestive of both acute and chronic malnutrition. Very commonly asked, if we have to assess the acute malnutrition, it is by weight for the height. Only chronic, it is for the height for the age, but both acute and chronic by the weight for height. So this is the most important parameter. Now we are using the ICDS based growth charts, or the multicentric growth reference study charts, or the MGRS charts, where we are having the three lines there. And first line is representing the 50th percentile, the second line is representing the -2 standard deviation, the third line is representing -3 standard deviation. So remember, it is the color zone, same like a traffic colors. It is the green, yellow, and here it is the reddish to orangish. So between the first two lines, it is healthy. Between the second and the third line, it is a mild to moderate degree of, or we can say the mild degree of mild to moderate is this malnutrition. And if it is less than -3, it is the severe degree of malnutrition. Clear? So we are taking the serial record of the weight of the baby, and height of the baby is also calculated, but weight is very important, and we are joining these dots. So the direction of this growth chart is more important. The single reading is not important, but the direction of the growth is more important. Okay. Then to know whether the baby is growing the weight or not, we should be knowing the birth weight of the baby. The average birth weight of an Indian baby is around 2.8 kgs, and if it is less than 2.5, we say it's a low birth weight baby. And at birth in the periphery, we are recording by the Salter's sling, and here the weight should be recorded within the first 1 hour of the delivery, because after that the baby is losing the weight. And this birth weight is supposed to be the very important single parameter to give us an idea about the chances of the baby survival. अगर बेबी का वेट, कोई बेबी आता है एंड we say इसका वेट 1.1 kg है, तो मन से निकलता है बड़ा मुश्किल है इस बच्चे का बचना. But if the baby weight is appearing like a 2.7, 2.8, हाँ बच जाएगा, अच्छा वजन है. So what I mean to say that if you hear about a weight of a baby, and automatically the reaction comes from your inside that whether this baby is able to survive or not. Suppose you find a baby of 2.9 kgs, you say, okay, the baby will survive, it will be remaining fine. But if you find a baby of around 1.1 or the 1.2 kg, you'll say, oh, baby is very low weight. We'll see what can be done best for this baby, or what is the prognosis of this baby. We cannot say right now. So we should be knowing the birth weight of the individuals. Then we are conducting another activity in the ICDS center in addition to the growth monitoring. So we are talking about the few points of the ICDS centers, that we are giving them the midday meal, and we know that food what we are giving should have the half of the required protein and 1/3 of the required calories. And the calorie what we are giving to a 6 month to the 6-year-old child is 500, in the pregnancy and lactating woman 600, and the malnourished children is 800. Now, please listen carefully. Now, we know that a beneficiary of the ICDS centers are 0 to 6 years, but we are giving the midday meal only in the 6 months to the 6-year old child, not the 0 to 6 years old, 6-month old child. The reason is obvious that in the first 6 months we are having only the absolute breastfeeding recommendation, so we are not adding anything from outside. Okay, and after 6 years the child is being admitted in the or child goes to the school with, for the next 10 12 years, and in the school some activity is being done every 6 months, that is the eye checkup, health checkup. Then we are doing their deworming, we are giving them the vitamin A supplementation also. So every 6 months the health checkup is done by the medical officer, and the eye checkup is either done by a school teacher or by the paramedical ophthalmic assistant who are posted at primary vision centers. And if a teacher is checking and the vision is less than 6 by 9, the child is referred to the primary vision center for correction of the refractory errors. And deworming is done by albendazole every 6 months to kill the worms, because they are the most important cause of anemia and malnutrition in our children. Okay. Then some activity we are doing every week, and that activity is we are giving the prophylactic iron folic acid supplementation, and every day we are giving them a midday meal. Okay, the maximum students in a class is up to 40. The space per child should be the 10 square feet per child. And the ventilation, that is the area of the door and the window, should be 25% of the floor area. Minimum can be more with that. And there must be the one urinal per 60 students, and minus type of the desk are preferred in the school. Now, all these activities, they are performed or they are being taken place under the one very important national program umbrella, and that is the National Health Mission. And we had already discussed this point that a main worker of this National Health Mission is the ASHA worker. It can be the urban ASHA or the rural ASHA, or urban ASHA is also called as the USHA worker. And the activities are being carried out. One is the RMNCH plus A activities. And here we are giving the facilities of the basic obstetric and the newborn care from the subcenter onwards, and the emergency obstetric and newborn care from the primary health center onwards. Then we are having the registration of all the pregnant women. So we can do their tracking. We are making their card, Jacha Bacha card, what we say, the mother and the child card we are preparing. And those areas where people are not able to come, we are sending our mobile van along with the health workers in that area with the medicine. They are examining the woman and giving them some medication, especially the iron, folic acid, and calcium medication or calcium tablets. Then we are having one important program as the Pradhan Mantri Matritva Vandana Yojana. Now, as per this program, we are giving the 5,000 rupees of the cash incentive in the three installment. The first at the time of the registration, when the baby registration is being done. Second is after the 6 months when the first antenatal visit is being completed. And the third is after the delivery, provided if it is a hospital delivery, the child had received the first vaccination of the 6 weeks of the duration or the 6 weeks of the age, and mother had accepted any contraceptive after the delivery. So these are the incentives we are giving in the three different installments. Then another is the Pradhan Mantri Surakshit Matritva Abhiyan. Now, Surakshit Matritva Abhiyan, here we are having the free antenatal checkup by the private practitioners on the 9th of every month, and they are putting the sticker. The green is the low risk, the red is the high risk, the blue is pH, you can remember as a blood pressure, B blood pressure for the pH, and yellow is for the other diseases. And in this way, when the patient is going for the delivery to the government sector, and where the doctor on duty or the staff on duty can look for this sticker and can say, okay, this is a high risk for the low risk woman. Then we are having the Suman activity, Surakshit Matritva Ashwasan, that we have to assure that a lady who is becoming pregnant will deliver in a healthy baby, and she should also remain healthy. It means there should be the zero preventable maternal and the neonatal mortalities. Then Arman is the advanced reduction in the mortality and the morbidity in the mother and the neonate. This is again the same thing that we have to give them the services so we can reduce the mortalities. Now we are having the Kilkari mobile app where per lady has to register from her own mobile number, and she is getting 3 to 4 audio messages per week for care of herself in pregnancy and care of the baby after the delivery. Now we are having another very important activity is Janani Suraksha Yojana. Now, very important scheme, and some questions has been asked from this Janani Suraksha Yojana, and this is for promotion of the hospital delivery. And here the incentive we are giving to the patient as well as to the you know ASHA worker also. Now, in the rural areas, in the low performance states, we are giving to the ASHA 600 rupees, and in the high performance also, that is the 600 rupees to the ASHA workers. And to the patient in the low performance states, rural areas is the 1400, and to the patient in the high performance states is the 700. So the total is 2000 to the patient and the ASHA in the low performance states in the rural area, and the 1300 in the high performance states. But in the urban areas, for the ASHA, it is the 400, and the patients in the low performance, 1000, high performance is the 600. This is for promotion of hospital delivery. And in this, we are transferring the patient free of the cost by the ambulance to the nearest hospital, and the free stay in the hospital, the free medication, the free food, and free all the operative services. And when the patient is being discharged, then the free drop back to the home. When we had seen the success following this Janani Suraksha Yojana, then a program started where we were giving the care to the newborn babies till 1 month also. But now we had extended this services to the 1 year of the baby, and that is the Janani Shishu Suraksha Karikram. So this is including the two components, the components of the Janani Suraksha Yojana, and another component is for the baby. And now it is still 1 year of the age. Then under this program, we are having the facility-based newborn care, means we are having the special centers where we can admit the babies, the newborn care corners at each delivery point, the newborn stability units, stabilizing units from the CSC at the CSC, and we are having the 6 beds here, and we are having the sick newborn care corners and district hospitals and the medical colleges. Here we are having the 16 beds, 12 for the patients and the 4 for step down. Then we are having the provision of the home-based newborn care also, and we had already covered this point that home-based newborn care is being given by ASHA worker, and there are the 7 visits if it is the home delivery. If it is the hospital vaginal, then 6 visits. Hospital cesarean, it is the 5 visits we are giving. Then we are having the IMNCI activity. IMNCI activity, as we had already covered in the functions of the multipurpose worker male, that based on the clinical features, the worker has to categorize the patient on the severity basis into the 3 categories: the green, yellow, and pink category. And this is for the children between the 0 to 5 years. If it is a green, the patient can be treated easily at home. If it is yellow, we are giving them the treatment but doing the follow-up. If no improvement, then referring to the higher center. Pink is alarming, then pre-referral treatment and immediately refer to the higher centers. And this is applicable for diarrhea, ARI, acute respiratory tract infections, and the measles, malaria, malnutrition. You can remember by DAM: diarrhea, ARI, measles, malaria, and malnutrition. Then we are having the special centers for admitting the severe malnourished children, that is a nutritional rehabilitation centers between the age group of the 0 to 5 years. Then we are having the activity or the कार्यक्रम for the बाल means बच्चे. So this is a Rashtriya Bal Suraksha कार्यक्रम, and just remember that Bal age is the 0 to 18 years, and here we are giving the services at the 2 places: in the ICDS centers for the children of 0 to 6 years, and in the school for the children between the 6 to 18 years for the detection of their deficiency, defects, disease, or the developmental delays. So 4 Ds you can remember. Then we had a Rashtriya Kishore Swasthya Karyakram. Kishore Avastha is the adolescents in the age group of 10 to 19 years, and we have to give them the nutritional education or the nutritional supplementation, the sexual health education. Then we have to deal with the substance misuse, their mental illnesses, violence injuries, non-communicable diseases, and we have to tell about the menstrual hygiene. Then we are having the Navjat Shishu Suraksha Karyakram also. And here we are giving the training to the health workers who are conducting the delivery for basic newborn care and the resuscitation. And this will in turn in reducing the infant mortality rate. So this is about your prevention in pediatric and obstetric. Very, very important topic. Now we discuss about the environment and health. Again, it is a very, very important topic, and many questions has been asked, especially about the water disinfection, chlorination, and insects. Now we all know that source of water supply in the rural area is a sanitary well. So the question is that what should be the minimum distance between the source of infection and the sanitary well is 15 meter or 50 feet. Then we can see the hardness of water because of either the calcium magnesium bicarbonate causing the temporary hardness, or it can be because of the calcium magnesium chloride nitrate or sulfates leading to the permanent hardness or the non-carbonate type of hardness. Now if a salt concentration is less than 1 milliequivalent per liter or less than 50 milligram per liter, it is the soft water. 1 to 3 is moderately hard, 3 to 6 is hard, more than 6 is very hard. But the important point is that hardness till 3 milliequivalent per liter, we can accept it. If it is beyond that, we have to do the softening. So the softening of the water is recommended if a hardness is more than 3 milliequivalent per liter or 150 milligram per liter. So see the unit very carefully. Then each and every water can be not we cannot use for drinking purpose. So what are the qualities of the drinking water recommended by the WHO? That most important is it should be free from the pathogenic organisms, and the most important pathogenic organism is the E. coli, that is a coliform organisms. The chloride level ideally should be less than 200 milligram per liter, but maximum upper limit acceptable is 600 milligram. The TDS should be below 500 milligram per liter. Maximum upper limit is 1000 milligram per liter. The nitrate should be less than 45 milligram per liter. Nitrite is less than 3 milligram per liter. Then how you are doing the purification of the water? The purification can be done by storage, then filtration, then disinfection. And out of this, the disinfection is very, very important. Now, filtration is done by the two type of filters, the slow and rapid sand filter. The point to remember is then in slow sand filter, the sand particle size is 0.2 to 0.3 millimeter. The rapid is the bigger size, zero point 0.4 to zero point 0.7. The layer of algae and the plankton which is present at the bottom of these filters is the Shumusdeck layer, which is present only in the slow scent filter, and because of this that quality of the water which is being filtered is better because it is killing some bacteria also. While in the rapid scent filter we don't have the Shumusdeck layer, so it is not killing the bacteria, so it is only mechanically filtering the water, so water quality is little bit inferior than the slow scent filter. In both the filters, to know the resistance of the head, that how much filter is being blocked, we are having the Venturio meter. Now disinfection is by the process of chlorination because it is protecting the water in the storage. Time also because we are leaving some extra chlorine as a free residual chlorine in the drinking water. So the chlorination is mainly because, or disinfection by chlorination is mainly because of the hypochlorous acid, and it is also because of hypochlorite ion. So read the question very carefully. The most important disinfecting agent is hypochlorous acid, but the disinfecting agents are both hypochlorous and hypochlorite ion. Clear? And this is killing only the pathogenic organisms, not the bacteria, ova, or spores or the cyst. Then the instrument by which we can measure the chlorine demand. Chlorine demand is nothing but it is a amount of the bleaching powder which is required to kill the pathogenic organism, and this is by the Horrocks apparatus. And the number of the first cup from onwards we are getting a color change is noted, and this number of the color cup into 2 will be the amount of bleaching powder in grams required to disinfect the 455 liters of drinking water. Okay, then another instrument is the chloroscope, and this is used to measure the free residual chlorine. Now when we had achieved the disinfection, then the break point comes when the free residual chlorine appears, and the free residual chlorine in the normal drinking water is around zero point 0.5 ppm at pH 7 after contact of 1 hour, while in the disaster it is zero point 0.7 or more, and in swimming pool it is 1 or more. Then to check for the combined and the free chlorine in the given water, we are having the orthotoluidine and orthotoluidine arsenite test. Orthotoluidine, it is in a early reading gives us some idea about the free chlorine, but later on it is giving the total chlorine. While the orthotoluidine arsenite test, it tells us the free and combined separately. So obviously the orthotoluidine arsenite test is preferred. Then if we want to know the contamination of the water and its source of contamination, then we will looking for the organisms. And if there is a presence of E. coli or the fecal streptococci, it is suggestive of the fecal contamination and fecal recent contamination. But if there is a presence of Klebsiella, it is a non-fecal but recent contamination. And if there is a presence of Clostridium perfringens, it is suggestive of the past or the remote fecal contamination. So in this way, we can assess the source of contamination, and we can take the action, and we can stop that point of contaminating the drinking water. So these are the points about the water section. Now another important component of environment is insects. Now we should be knowing that what are the various diseases caused by various insects. Now this is the image of the various insects, and again very commonly asked in the examination as the image based question, or they can give you the image and they can ask what disease is caused. So you have to do the two in one question, that identify the image and tell the disease. So first is the house fly. This is your louse, and this is flea, and this is your mite. Then these are the four mosquitoes. Now we have to identify if they are sitting with an angle, it is your Anopheles mosquito. If they are sitting parallel with the hunchback appearance, is the Culex mosquito. If they are sitting parallel with the hunchback appearance with the white spots on the body, it is your Aedes mosquito. And the hunchback appearance again with the blackish discoloration is the Mansonian mosquito. But the three mosquitoes, Anopheles, Culex, and the Aedes, are very commonly asked. And this is your redwood bug. Sandfly is again a very commonly asked image, and these are the ticks, the hard tick and a soft tick. Now, if we talk about the various diseases caused by these insects, the housefly is simply transferring the infection like diarrhea, cholera, typhoid, or all waterborne infections and trachoma. The Anopheles is causing the malaria. The Culex is causing the filariasis, Japanese encephalitis, and the West Nile fever. But remember one point, that filariasis is mainly caused by the Culex, but can be caused by other mosquitoes also. The Aedes is responsible for the dengue fever, chikungunya, yellow fever, Zika virus, and the Rift Valley fever. The Mansonian is again by causing the filariasis. Okay. Now, sandfly you can remember as the COSO. It is the Kala-Azar or visceral leishmaniasis, the oriental sore, sandfly fever, and Uriah fever. Now, sissy fly is causing the sleeping sickness or African trypanosomiasis. The black fly is causing onchocerciasis. Redwood bug is causing the Chagas disease. The louse you can remember as an ETR, like an MTR masalas we had. Epidemic typhus, strange fever, relapsing fever, or pediculasis. The flea is causing the endemic typhus. So we had a three type of the typhus: epidemic, endemic, and the scrub. Epidemic is by the louse, endemic is by flea, and the scrub typhus is by mite. Okay, now please listen carefully that plague is also caused by the flea. If they had simply asked the plague, then it is by the flea. But if they had asked what is the vector or the causative agent for the pneumonic plague, then remember it is the aerosol route, because it is transmitted through the respiratory route through the droplets and droplets nuclei. It is not by the flea. So read the question carefully. The mite is causing the scrub typhus and rickettsial pox. Clear? Then we are having the ticks. The soft tick, it is causing the Kyasanur forest disease outside India, but in India it is caused by the heart tick. Then Q fever, again the first answer should be that no vector required, or it is through the aerosol route, or it can be caused by the soft tick. Clear? And relapsing fever, it is mainly by the louse, but it can be caused by a soft tick also. The heart tick is a KFT in India, Rocky Mountain spotted fever, tularemia, babesiosis, or Indian tick typhus. Then, if we say that how we are going to control the mosquitoes, the best is the larvicidal control, and that is your primordial level prevention. We are trying to avoid the risk factor, that is the mosquito development. So, environmental is the best, where we are not giving them the breeding sites, and we are putting some chemicals, the Paris green dust, to kill the Anopheles larva, because these larvas are parallel to the surface, and the abate or the Temiphos to kill the Culex aedes or the Minsonian larvas. Or we can leave the fishes, the Gambusia fishes, and they will eat all the larvas. ये इनको ये नहीं पता होता कि ये एनाफीस का लार्वा है, मुझे नहीं खाना, ये क्यूलेक्स का लार्वा यस बहुत टेस्टी है, इसे मुझे खाना है, या ये मेंसोनियन का तो भैया बहुत ही ज़्यादा टेस्टी है, इसको तो मैं खाऊंगी ही ज़रूर. नो. So Gambusia fish is whatever the larva is coming in way, they can eat the all the type of larvas. Or we know that Minsonian larvae, they are attached to the roots of the sea plants, so we have to pluck the plants. So along with that, the Minsonian larvae are coming outside. And this is how these larvae are looking, that Anopheles larva, it is parallel to the surface, opposite to the adult mosquito. The Culex aedes are suspended to the water surface, and Mansonian, they are attached to the roots of seed plants. Then if we talk about the control of various mosquitoes, then either we can have the spray, and natural are only the pyrethrum, which is non-residual, while the synthetic are DDT and malathion. Clear? The point to remember is that DDT spray we are doing every 6 months, and malathion is every 3 months. And the spray technique in the malathion is the ultra low volume spray, and for the pyrethrum we are using the space spray technique. The DDT as such is not used alone because of the resistance it is using along with the pyrethrum. Now, if we are not able to kill the mosquitoes, either you have to kill the enemy or you have to hide yourself in the bunker. This is the a simple rule. So our bunkers are the mosquito net, and the size of the mosquito net should be, or hole size should be less than 0.0475 inches in size, and we prefer the rectangular type of holes. Then if we are still not able to stay inside the net, then we have to apply the various repellents also, and these repellents are available in either in the form of ointments, in the form of various skin patches are there, or we are having the various spray also which can kill the mosquitoes, or we are having the all outs also. Or another important point is that sometimes we are coating these mosquito nets with insecticidal agents, and these are the insecticide treated bed nets, or can be resistant to the washing as the long lasting insecticidal bed nets. So these are the important points what we have to remember about the various insects. Then another important section is air. Now we all know that air pollution is increasing day by day, and at this moment, the Delhi we are having the very high air pollution, and this is actually the post Deepavali, and there is a burning of this parali. It's a husk in the nearby states from Haryana and the Punjab. We are having so much of smoke here. Now, air pollution is being controlled by a Central Pollution Control Board, and we had also seen that it is controlling the biomedical waste also under the Ministry of Environment and Forest. The most common air pollutant is the carbon monoxide, but the best indicator is the sulfur dioxide. The soiling index is not related to the soil, it is related to air, remember. The cooling power of the air is air temperature, humidity, and the velocity. Now, earlier we were measuring the cooling power of the air by Carter thermometer, but now we are using this Carter thermometer only to measure the velocity or the air movement. Now we are measuring the temperature by the globe thermometer and the humidity by sling psychrometer. So this image number one is your Carter thermometer, the image number two is your globe thermometer, the number three is your sling psychrometer. The globe number four, it is measuring the wind velocity as anemometer, and the image number five, it is measuring the wind direction and it is a wind vane. Then we are having the PM 2.5 and PM 10 particle size. So just remember the one point, that point 2.5, it is are going down to the alveoli, so they are causing the changes in the lungs. And the PM10, they are being trapped in the upper respiratory tract, so they are causing more of pharyngitis. Okay. Then we know that there is emission of the greenhouse gases, and which is increasing the air temperature or the environmental temperature. So we are having the various meetings, and the recent meeting took place in Glasgow, and this is to overcome the greenhouse gas effects. And in that, the different countries had to give their submission that what activity they are taking to avoid the greenhouse emission. Either they are planting more and more trees, or they are using more and more of the solar energy. So the greenhouse gases are mainly the water vapors, the carbon dioxide, methane, nitrous oxide, and the chlorofluorocarbons as hydrofluoro, perfluoro, and hexafluoride. And we had two very famous agreements. That one was the Kyoto Protocol in the 2005, another was the Paris Agreement, and was this took place in 2015 in Paris, and currently we had the Glasgow Agreement, and this took place in 2021, and this is in the Glasgow. And the same, they had decided that they have to keep the increase in the temperature below 1.5 degree centigrade. So they have to keep the rise in the global temperature below 1.5 degree centigrade. So this was actually the extension of the Paris Agreement, and they had accepted it. So these are the important points about the air pollution. Then the important points to remember in sound, that maximum tolerable sound without the damage is up to 85 decibel. The rupture of the tympanic membrane happens if we are having the sudden exposure of a sound to more than 160 decibel. And if we are having the continuous exposure to a sound around 100 decibel, we can have the permanent hearing loss. And the sound which is permitted in the ICUs is 20 to 35 decibel. Now, if we talk about the housing conditions, that a space per person required in the house is 17 to 90 square feet, or more than 500 cubic feet per person, and the door and window area should be more than 40% of the floor area. There should be around 2 to 3 air change in the residential area, and the 4 to 6 air change per hour in the commercial areas. Now, if we talk about the radiation, that maximum permissible upper limit of the whole body radiation is 5 rad per person per year. It can be protected by use of lead apron having the minimum thickness of the zero point 0.5 millimeter. Okay. Then we have to dispose the waste from the houses. It can be the fecal waste or non-fecal waste. Now, if it is the simple domestic waste, that is the refuse. And the best method to dispose is the sanitary landfilling or controlled tipping. But if we are having the liquid waste without the fecal matter, is the silage from the kitchen, and the liquid waste with the fecal matter is the sewage. It is from our toilets. Okay, and it is having the 99.9% of the water, but 0.1% is a solid, and that is very dangerous. Now, strength of the sewage is assessed by the biochemical oxygen demand, and it is more than 300 milligram per liter. It is suggestive of strong sewage. Then we should be having the some water column in our toilet seats, and the minimum height should be 2 centimeter or 3 by 4 inch. This is called as sanitation barrier. Now, how we are disposing our fecal matter, and in those areas where we are not having the underground sewage pipeline, it is discarded by septic tank, and where inside the septic tank we had anaerobic oxidation, and outside the septic tank we had aerobic oxidation. While in the areas where we had the underground sewage pipeline, the fecal matter, it is going to the sewage treatment plants, and we are having the aerobic oxidation, and this is done either through the trickling filter method or activated sludge process. So this is all about your environment and health. So okay, right here we are taking a break for 15 minutes, and then we'll discuss the remaining topics. So time by my watch is 4:35. So we'll start our class at 4:50 p.m. Okay. Hello, friends, welcome back. Now we'll be talking about nutrition. And very important section of nutrition is food adulteration. They commonly ask that what is the toxin, what is the agent, in which food stuff it is being mixed, and the important point about the disease. So Lathyrusm is because of the Lathyrus sativus, which has been mixed with the yellow pulse. Toxin is the BOA, beta oxalyl aminoalanine, and this can be prevented by giving the vitamin C supplementation in endemic areas. Now, epidemic dropsy and endemic ascites, these are the two conditions where very commonly they ask about the toxin because of their confusing words. Epidemic dropsy, and we discuss with a small mnemonic that EDS, BDS. So any toxin starting with the name S, if you're not able to remember the whole name as a sanguinarine, is the toxin of epidemic dropsy. And this is because of mixing of the argemon seed oil in the mustard seed oil. And argemon seed oil is also the prickly poppy seed oil. And this is detected by paper chromatography, which is highly sensitive to detect the contamination of 0.0001% of contamination, and this is causing the sudden swelling in the distal part of the body, leading to cardiac failure. Then endemic ascites is, you can remember as an app, P for pyrrolizidine, and this is because of mixing of the crotolilla seeds in the millet, and this toxin is causing the liver damage, leading to ascites. Then we are having the aflatoxicosis because of the aflatoxin, and they don't ask the toxin because it is very clear aflatoxin, but the question is asked that it is because of a fungus, that is the aspergillus flavus, which is mixed with the grains or affecting the grain during the storage because of presence of moisture, and this is causing the liver cancer. So this was the question asked, that liver cancer is caused by which condition? It is by aflatoxin. Now, ergotism, it is because of ergot alkaloids or clavin alkaloids, which are present in the fungus Claviceps fusiformis, and which is infiltrating or affecting the plants while they are flowering. So, when the seeds are prepared or seeds are formed, already they are infected, and this is causing the peripheral vasospasm, leading to development of gangrene. So these are the important points about food adulteration. Then another important aspect is about milk. We know that milk is supposed to be a complete food for especially children, but it is deficient in vitamin C and iron. So those children who are being given only milk, they are having iron deficiency. Now, to kill the pathogenic organisms present in the milk, which can be transmitted either from the animal or from the handlers, then this process is called as pasteurization. So, partial boiling and sudden cooling to kill the pathogenic organism, and this is done by VAT method or the Holders method, where we are boiling at 63 to 65 degrees centigrade for more than 30 seconds. But most commonly used method is the high temperature short time or flesh method, where we are boiling at 72 degrees centigrade for only 15 to 30 seconds. Or we can have ultra high temperature method, where we are boiling under pressure at 125 degrees centigrade for few seconds. And this is killing only the pathogenic organisms, coliform organisms, typhoid bacilli, brucella, Q fever, but not the ova, cyst or spores. Then test which you are doing before pasteurization to know the degree of contamination is methylene blue, and after pasteurization to know the efficacy of the procedure, it is phosphatase test, coliform or standard plate count. The best is phosphatase, that is an enzyme should be absent. Now, everywhere we talk about the balance. So the diet which you are taking should be a balanced combination of all the components. So energy which we are getting from the food, it is the protein should contribute in giving a 10 to 15% of the energy. The fat is 10 to 30%, but Indian guidelines says up to 20% because we had a different BMI criteria. And carbohydrate is giving energy up to 60 to 70% in a normal condition. But if you have to lose the weight, then we have to cut this carbohydrate. Then only we can burn our fat. Just a minute. So if we have to lose our weight, then we have to cut short this carbohydrate so we can burn our fat. Now, very commonly they ask that how much should be the caloric requirement by the different individuals. We know that it is depending upon multiple parameters, but here we are considering on an average the reference person means of a standard height, weight, and the difference on the basis of their work and the sex. So, in the sedentary worker male, start with the 2100 calories at 627 for moderate, and for the heavy plus 8 is 35. For the female, you can start with 1700 plus 4 for the moderate, 2100 plus 6 for 2700 calories. Now, question is asked that extra calories required during the pregnancy is 350 of the basic calories. So read the question very carefully whether they're talking about the sedentary male, sedentary female, or the moderate worker female, or the heavy worker female with a pregnancy. Okay. Now, if they didn't mention the trimester, go with a 350. But if they had mentioned that a first trimester, then in the first trimester, the less energy is required is plus 150. Okay. So be very careful. Now, in the lactation, the first 6 months, it is plus 600 of the basic calories, and after 6 months, it is plus 520 of the basic calories. Now, the daily requirement is either on the basis of that is required on an average is the 50% of the individual is the estimated average requirement, but that is not usually given. But what we are using the doses as the RDA values, that is a recommended dietary allowance, and this is covering the mean plus 2 standard deviation values. So this is covering at least the population of 97.5% population demand. Okay. Now, what are the basic requirements of the food components as per the RDA? This is again a very, very important chart, very commonly asked in the examination. And we have to remember about the calcium. That calcium, it is 1000 milligram per day in men, and 1000 in the female also. And during the lactation only, the demand increases up to 1200 milligram. Okay. If we talk about the iron, the maximum during the pregnancy is the 40 milligram per day. In the lactation, first 6 months and later on is the 23 milligram. And in the moderate worker female, it is on an average is 29 milligram per day, and in the man it is 19 milligram per day. The iodine in the man, it is 150 microgram. Sorry, this is not a milligram. This is 150 microgram per day. And in the moderate worker female, again it is 150. In the pregnancy, it is increasing up to the 250, and in the lactation, it is 280. Clear? The folate is again, it is the microgram per day. It is 300 microgram in the men, the 220 in the female non-pregnant, but maximum in the pregnancy female, it is 570. Earlier it was a 500. This is the new guideline. It is 570. And in the lactation, first 6 months is 330. Later on also it is 330. Then if we talk about the vitamin B12, it is again microgram, and it is 2.2 in the man and a woman, and in the pregnancy additional 0.25 microgram, and in the lactation is maximum plus 1 addition. Clear? The vitamin A, this is again it is microgram, and it is 100, it is 1000 in the men, 840 it is in the female, and 900 it is in the pregnant female, 950 in the lactation. While vitamin D, it is 600 international units, it is in all the categories. This vitamin A is in the international units. So vitamin A is in the international units. The vitamin D is also in the international units. So vitamin D is same throughout the status. The calcium increases during the lactation. Then vitamin A, it is if you talk about the woman, it is maximum in the lactation, and that's why, if you can recall, we had discussed we are giving the 3 lakh international 3 lakh international units of this vitamin A. We are giving just after the delivery to a mother. So this is stored in the mother's body, and it is being transferred to the baby through breast milk. Then we are having the national programs in relation to the nutrition. The midday meal program, it is providing the food as half of the protein and one third of the calorie, and this is the logo. And you could see that boys and the girls, they are sitting together with a plate having the meal. And this is under the Ministry of Education, that is under control of HRD department. The total protein what we are giving in a child of class 1 to 5 is 12 gram. In class 6 to 8 is a 20 gram of protein we are giving. Then we are having another very important program in relation to the vitamin A deficiency, and that is a vitamin A prophylaxis program. The overall deficiency, it is xerophthalmia. The first symptom is the night blindness. The first sign is conjunctival xerosis. The most important clinical sign is the Bitot spot, and the most sensitive indicator of the deficiency is the serum retinol. So these are the four different questions. Read the question very carefully. Now, the WHO grading of the xerophthalmia as per the appearance is the 1A is conjunctival xerosis, 1B Bitot spots, the 2 corneal ulcer, corneal xerosis, the 3A is corneal ulcer, and the 3B is the keratomalacia. Okay. Then another point is that how we can say that it is a major public health problem when prevalence of night blindness is more than 1%, commonly asked. Prevalence of the Bitot spot is more than 0.5%, and the serum retinol level less than 10 microgram per deciliter is seen in more than 5% of the population. Now, for the deficiency, we are giving the high doses. The one dose, suppose today, that is a day one, the second after the 24 hours, the next day, day two, and the third dose is 2 to 4 weeks after the first dose. And amount is if a age of a baby is less than 1 year, we are giving the 1 lakh international units per dose. If it is more than 1 year, it is 2 lakh international units per doses. Okay. While we had already discussed that for prevention, we are giving the total 9 doses to our children. Total amount of the vitamin A given is the 17 lakh international units starting from the 9 month of the age. Then we are giving every 6-month interval till 5 years. Then if we talk about the sources, the best are the animal sources, and the richest source is the halibut oil, followed by the cod liver oil. So this is about the vitamin A prophylaxis program. Now, another very important program we are having in relation to anemia is the Anemia Mukt Bharat or Intensified Iron Plus Initiative. As you could see in this logo, we are having 6 individuals. So we are having the 6 beneficiaries of this program. And these beneficiaries are the children between the 6 to 60 months. And as I said earlier also, that as till the 6 months the baby are breastfeed, so we are not giving any medication also from outside. So 6 months to 60 months, then 6 to 10 years, and 10 to 19 years, 20 to 49 years, pregnancy and the lactation. These are the 6 beneficiaries. Now the very important question, because this chart is very important, and they ask what is the composition of the iron tablet what we are giving and the frequency. So always remember, in the children between the 6 to 60 months or 6 months to 5 years, we are giving bi-weekly in a syrup formulation, and the dose is containing the 20 milligram of iron and 100 microgram of the folic acid. While in the 6 to 10, 10 to 19, and 20 to 49 years, what we are giving prophylactically is the weekly administration. The difference is that till 10 years, we are giving the smaller doses, that 45 milligram of iron and 400 microgram of folic acid. And after that, we are giving the adult dose as 60 milligram of elemental iron and 500 microgram of folic acid. But important point, that in pregnancy and the lactation, we are giving them the daily administration. Clear? So this is important point. Now, how we can say the person is anemic? If cutoff level or the hemoglobin, it is less than 13 gram in the male, in the non-pregnant female less than 12 gram, or in the pregnant female less than 11 gram as per the WHO. But Indian guidelines says that if it is less than 10 gram, we see the lady as anemic. Okay. Then in the children between the 6 months to 6 years, 11, and children between the 6 years to 14 years is the 12 gram is the cutoff level of hemoglobin for anemia. Now, the most sensitive indicator of the iron deficiency anemia is a serum ferritin level. One important point is that when we are giving the iron supplementation, initially hemoglobin increases, and then the extra iron is being stored in the uh, body, in the bone marrow. So like we are storing our or depositing our extra salary or the income in the bank. So same like we are storing our extra iron in our storehouses in our body. So it will take 3 more months. So we have to continue the iron folic acid tablets for 3 more months after having a normal hemoglobin blood level. Okay, and always we are giving this iron with the folic acid to avoid the megaloblastic anemia, and seem like the calcium is always given with the vitamin D for its best absorption and utilization. Then we are having the program related to the iodine deficiency. And if the prevalence of the goiter is more than 10%, we say it's a major public health problem. And for this prophylaxis, we are using the iodized salt, and the iodine concentration at the production level should be more than 30 ppm, equal or more than 30 ppm, or in the consumption level should be equal or more than 15 ppm. And we are having the a concept of a life-saving dots, means we are providing the dots or the bindi what a Indian lady put on their forehead of the multiple colors from the government hospitals, and the glue on the back of these dots, they are containing the desired iodine dose, so they are acting as an iodine patch. So they are applying on the forehead and the iodine is absorbed through the skin. Then we are having the national program for prevention and control of the fluorosis. Here you should be knowing the normal fluoride label in the drinking water is zero point 0.5 to zero point 0.8 ppm. No confusion with the free residual chlorine normal level. It is zero point 0.5 ppm. It is fluoride is zero point 0.5 to zero point 0.8 ppm. The maximum upper limit is 1.5. If it is beyond that, it is a fluorosis. 1.5 to 3, it is affecting the teeth, leading to the dental fluorosis. 3 to 6, it is affecting the bone, it is skeletal fluorosis. And if it is more than 10, it is affecting the joints and ligaments, stiffness. Person is not able to walk, that is a crippling fluorosis. And if a fluoride level is less than zero point 0.5 ppm, it is causing the damage to the enamel and the nerves are exposed, leading to the dental caries. Then if a fluoride level is high, then we have to reduce, and this is by the process of the Nala-Gonda technique. And here we are adding the lime, alum and the bleaching powder in that particular order to reduce the or decrease the fluoride concentration. While for the treatment of the dental caries, we are giving them the fluoride containing toothpaste. But always remember that keep these toothpaste away from the children, because they are swallowing this toothpaste and it is leading to their accumulation in the body of iodine and fluorine, and this fluoride level will increase and they can have symptoms of excessive fluorine. So we have to avoid these fluoride containing toothpaste to be used by children. Then we are having another program as National Nutrition Mission or the Poshan Abhiyan. And here we have to make the India free from malnutrition by 2022. And this is the logo of Poshan Abhiyan. Then what is the role of various macronutrients in the diet? Macro is nothing but it is the protein, fats and the carbohydrate and fiber. Now protein, as we all know that average quality protein, if you are using with the NPU value of 65, it is 1 gram per kg per day. And what is an NPU value is a net protein utilization, means it is depending upon the digestive coefficient, means how much is digested and absorbed, and the biological value, how much it has been retained in the body after absorption. Clear? So the protein with the maximum NPU value is 96 is for the egg protein, and the protein with the maximum concentration weight by weight is a soya protein with a 43 to 44%, but its NPU value is less as a 55. So here one point I just want to say as a success mantra. For the remaining days for your exams, whatever you are reading, it should be with the full concentration. So your NPU value should be almost 100%. Means whatever you are reading, you should be able to recall in your examination. So you have to study with full concentration and clearance of your concepts. Then there are certain conditions where amino acids are deficient in some food products. So pulses are deficient in mainly the methionine and cysteine. You can remember as in PCM mnemonic. And the cereals are mainly deficient in the lysine and to some extent is threonine. You can remember as TLC. The maize is another very important portion asked in the examination. The maize is deficient in the tryptophan, and whatever the small amount of tryptophan is there, it is not being converted into the niacin because of excess of leucine that is acting as a negative catalyst. So there is a very less amount of niacin and causing the pellagra, because niacin is a vitamin B3 deficiency will cause pellagra. So indirectly we see the maize is a pellagrogenic diet. एक तो पढ़ने का मन नहीं है, दूसरा कोई फ्रेंड आ गया उनका बस मत पढ़ आज बहुत हो गया चल उस फ्रेंड का बर्थडे मनाने चलना है. So these are the negative catalysts. So keep yourself away from the negative catalysts in your life, especially at this moment till your examination. Then few points about the deficiency of these essential amino acids. Then if there is a deficiency of the amino acids or the proteins with the energy, the baby is marasmic. And if there is a deficiency of only the proteins but energy is normal, then it is leading to kwashiorkor baby. Then, if we talk about the fat, that the most important essential fatty acid is the linoleic acid, and the richest source is the safflower oil. And the second important essential fatty acid is the linolenic acid, and the richest source is the flaxseed oil. And if we talk about their carbon bonds, the saturated fatty acid is highest seen in the coconut oil, while unsaturated fatty acids, obviously they are better, they were the saturated one for cardiac risk. And monounsaturated are highest in the groundnut oil, and the polyunsaturated fatty acids are seen in the safflower, sunflower, rice bran, mustard oil, or the corn oil or flaxseed oil. Okay, then deficiency of the essential fatty acids as well as the deficiency of the vitamin A both can cause the skin like frog or the toad, rough scaly skin, and that is called as phrenoderma. Now carbohydrate is only to provide the energy, and as per the condition we have to use the glycemic index. And in the diabetic patients we have to use the food with a low glycemic index less than 55, and to the athletes we have to use the food with a high glycemic index. And fiber are just to give the bulk to the stool and maintain the intestinal functions. Then if we talk about the micronutrients can be the vitamins and the minerals. The vitamin A deficiency we had discussed are all detailed. It is causing the xerophthalmia. B complex, thiamine B1, the deficiency leads to beriberi and Wernicke's concept of psychosis, very commonly asked in examination. And this beriberi, it is seen in the polished rice eaters because B1 it is present in the outer core. So if we want to preserve this B1, we have to do the parboiling. So parboiling, it is for preservation of the prevention of beriberi, and where we are preserving the B1. Then B2 deficiency is causing the angular stomatitis, and this is the riboflavin deficiency. Now B3 is the niacin, and its deficiency is causing the pellagra. And the most important is the dermatitis in the neck, and very commonly asked as an image based question also, and Kessel neck appearance it is giving. So pellagra, it is characterized by diarrhea, dementia, dermatitis, and the death. The B5 can lead to the deficiency as burning feet syndrome. It is pantothenic acid. The B6 pyridoxine, peripheral neuritis is as a deficiency, and those who are taking the ETT, because the isoniazid is B6 antagonist, so we have to supplement B6 on a patients with ATT. Then biotin deficiency causes hair loss. The folic acid deficiency can lead to the congenital malformation, especially the neural tube defects and the megaloblastic anemia. Okay. Then B2 cyanocobalamin and its deficiency leading to megaloblastic anemia and the subacute combined degeneration of myelin sheath of the spinal cord. Now, if we talk about the vitamin C, that role of James Slin, who detected that scurvy can be prevented by fresh citrus fruits, and later it was detected that these fruits are containing the vitamin C, and the deficiency of this vitamin C can lead to the bleeding from the gums, that is scurvy. And vitamin C is acting as a very good antioxidant. The other antioxidants richest source, the richest or highly active is the vitamin E, and others are the A, C, selenium, and lycopene. And richest source of vitamin C is the amla or Indian gooseberry. If we talk about the vitamin D, the most active form is calcitriol, 125 dihydroxycholecalciferol, which is formed in the kidney. And its deficiency in children causing rickets, and in adults it is osteomalacia. And the richest source is the halibut oil. Now, vitamin E, the richest source is wheat germ oil, and vitamin K, that deficiency will lead to the hemorrhagic diseases of the newborn. And we know that newborn intestine is sterile, otherwise, the vitamin K is synthesized in the intestine. So, we are giving the vitamin K injection mandatory to each and every child just after the delivery. And the natural forms are fat soluble K1 and K2, the K3, the synthetic, which is water soluble manantian. Now, if we talk about the mineral, we have talked in detail about the iron, iodine, and the fluorine, the calcium. The deficiency will lead to osteopenia or the osteoporosis. And we know that a grain which is having a high calcium concentration is ragi. Now, zinc, again, a very important mineral, and its deficiency will lead to the diarrhea or infertility, delay in the wound healing, or hair fall. And one condition where there is a defect in the enzyme which helps in absorption of the zinc from the intestine, leading to the dermatitis, that is ectodermatitis enteropathica. And selenium is a strong antioxidant, and its deficiency will lead to the Cajun's cardiomyopathy. And we are using the food stuff that has to pass through the various standards. So one is the Codex Alimentarius, that is a standard as per the international market. The parallel to the Codex Alimentarius in India, we are having the PFA standards, that is standards to be fulfilled as per the guidelines of the PFA Act. And if we are having the quality better than the PFA guidelines, it is having a BIS marks, the Bureau of Indian Standard. And the agricultural products are being approved by the EGMA. So EGMA standards has to be fulfilled for the agricultural products. And for any edible items, now we are having the FSSAI mark, means any company has to get the license from the FSSAI, that is a Food Safety Standard Authority of India, and that FSSAI mark should be present on each and every food stuff. So these are the few important points about the nutrition. Now we'll be talking about the various diseases. As we all know that in the diseases section, that we should be knowing that basic points, that what is an incubation period, what is period of communicability, what is serial interval, and what who are the carriers, who are the subclinical cases, and in which disease we had these carriers, or carriers are not seen in which diseases, and if there is any specific investigations, then any specific drug of choice. And very important is the role of national guidelines, what are the national programs related to that particular disease, and what are the goals in relation to the disease that we are trying to do the elimination till what time. So we'll be talking about the basic points in the diseases. So first we'll see the basic general definitions before starting the specific diseases, that who are the primary and the secondary cases. Primary is the first case, and the cases who are developing from the infection in the primary case is the secondary cases, but very commonly asked is the index case. So index is the first reported case, or it may be primary or secondary case. Now if we talk about the definitive cases, the definitive case means where the sexual cycle is completed, and intermediate are where the asexual cycle is completed. Now, if we talk about the malaria, the mosquito is supposed to be the definitive host in malaria. And if we talk about the filaria, the man is the definitive host, and mosquito is supposed to be the intermediate host. And if we talk about the echinococcosis, in the echinococcosis, the dog is the definitive host, while the man is intermediate host. Okay. Then, if we talk about the various time duration, the time interval between the entry of the organism to the appearance of signs symptoms of the disease, it is called as the incubation period. Then a time interval between the entry of the organism to the 50% of the cases, that is the median incubation period. And the time interval between the entry of the organism till the maximum infectivity of the disease is the generation time. Okay. Then the time interval between the primary and the secondary case is the serial interval. Now, period of communicability is the during which the disease can be transmitted from one to another. So, and during this period of communicability, we have to isolate a person because he can transmit the infection. So, if we are separating the individuals, if it is a diseased person, then till period of communicability, it is isolation. And if we are exposing the or separating the healthy person who we had a doubt till the maximum incubation period, it is your quarantine. So remember that all these parameters are a part of incubation period except the period of communicability that is not related to the incubation period. That is something different. Okay. Then case fatality rate is number of the deaths per 100 total cases, and this is giving us an idea about the severity of the disease or the killing power of the disease, not the infectivity. The infectivity is assessed by the secondary attack rate. And remember one very important point, that here the number of the secondary cases in the single incubation period per 100 total number of the susceptibles. That is very, very important, that in the single cases we have to calculate the secondarily affected cases. And while making the calculations or solving a small numerical, to calculate the susceptible cases, always we have to exclude the primary case and the vaccinated individuals because they are now not susceptible. Remember this point. So secondary attack rate gives us an idea about the infectivity of the disease, and the case fatality rate gives us an idea about the severity of the disease or the killing power of the disease. Okay. Then what are the various type of the biological cycles in the intermediate host or the factors? Then if organism is increasing in number, then this is propagative. Propagate means chalna barna. And if there is an increase in the number along with the maturation, then it is cyclopropagative. Means cycle is also developing and propagation is happening. But if it is only increasing in the size or the maturation is happening, then it is cyclodevelopmental. Means no propagative, but cycle is only developing. So remember these three words. Propagative, only increase in number; cyclo-developmental, only increase in the size or the maturation; cyclo-propagative, both increase in the number and the maturation both. Okay. Now, who are the reservoirs? Reservoirs means where the organisms are persisting for their survival, and whenever they are getting the chance, they can go to another individual. And source is simple, the channel of transmission. So reservoir can be the living or the non-living, like a soil for the tetanus, fungal spores, or it can be the human or animal reservoirs for the all zoonotic diseases. And the human reservoirs can be either the individuals with the infection, or only they are carrying the organisms as a carrier, or if the infection is present, then they could be the symptoms or the clinical infection, clinical cases. And infection is there but no symptom, these are the subclinical cases. So we should remember that various diseases where we had the no subclinical cases and carriers, where we had only clinical cases, where we had the carriers, because the questions are asked in the examination. If we talk about the incubation period, now you can remember like that a short, medium, and the long incubation period. The short means it is up to 7 days, and medium means it is 1 week to the 4 weeks, or the 1 week to 1 month, or it can be the long incubation period. It is between the 1 month to the years, like that. Okay, so these are the few basic points. Now we'll talk about one very important group of the diseases, that is national vector-borne disease. And we had a program to control these vector-borne diseases, and the logo we have to identify in the exam, and how we can identify this logo. And this logo can be identified, the family, it is covered with a circle, means a protective cover, and outside that the mosquito is sitting. Then the question is asked that which are the diseases included under this program. So we had 6 diseases under this program: malaria, filariasis, dengue, chikungunya, Japanese encephalitis, leishmaniasis. Now here the question can come in your mind that leishmaniasis is not caused by the mosquito, it is by the scent fly. Why we are including? So it's included all the vector bonds. Means if you are having an insecticidal spray, it will be killing the scent fly also, but not the yellow fever. The reason is that we don't had the yellow fever in India, so we don't want to control. So we had only the quarantine guidelines that we don't want the yellow fever virus to enter inside the India, and that's why we don't have the control program for a yellow fever. Now, important point about the malaria, what we have to remember is that how we do the diagnosis and how we are going to do the treatment. The diagnosis is done by peripheral blood smear examination. This is the most important or the sensitive test for the confirmation of the malaria. And the slide is prepared by the multi-purpose worker male, who is a main worker of active malaria surveillance, very commonly asked in examination. The slide can be prepared either at home as an active surveillance or in the fever treatment depots. These are the infrastructure of malaria program, or in the sub-center, the patient is coming in the sub-center. But they are transferred to the PSC. They are sent to the PSC because checking is done at the PSC. So no confusion, they can be prepared in the periphery, but they are checked at the primary health center by the lab technician. Clear? And we are preparing the two slides, the thick and the thin slide. The thick is to confirm the malaria because the more amount of blood is there, and then we have to see that what type of malaria this is, either the vivax or the falciparum, because the treatment is as per the species. So if a person has been diagnosed with a vivax malaria, suppose, or the falciparum, then the treatment is based on the state, especially in the female, whether they are the pregnant or non-pregnant. So if I say in the general population, the vivax, the drug of choice is the chloroquine, given in the 3 divided doses for 3 days. Total is around 25 milligram per kg. So 10, 10, 5 like we give. And we are giving the primaquine to avoid the relapse cases. And the dose is 0.5 milligram per kg per day for 14 days. But if it is a falciparum, then it is depending upon the geographical states, because maximum falciparum cases are happening in the northeast states. So we have to give the higher group of the drugs, and which we are not giving left and right to the other states, because here the mosquitoes, they are responding well to the lower group of the drugs, and we don't want to develop the resistance. So in the northeast states we are giving the artemether lumefantrine for 3 days, and in the other states we are giving the artesunate sulfadoxine pyrimethamine artesunate for 3 days, single dose of the sulfadoxine and single dose of the pyrimethamine, while in both the cases we are giving the single dose of the primaquine as 0.75 milligram per kg. So remember, in the vivax we are giving for 14 days lower dose 0.25 milligram per kg, while in falciparum we are giving the higher dose 0.75 milligram as a single dose. Clear? But if a lady is pregnant, in that case, the if a lady is pregnant, in that case, the chloroquine is the drug of choice for the vivax infection in all the trimesters, and no primaquine has to be given. And in the falciparum, in the first trimester, the quinine is the drug of choice in all the states, whether it's the northeast or other states, and no primaquine. But in the second or third trimester, we have to give as per the state's guidelines, plus primaquine is avoided. And one important point more in the diagnosis is that in those areas where we are not getting the report within 24 hours of the peripheral blood smear, we can go with the rapid diagnostic test kit also. Now, the another point is that what are the drugs we are giving for the prophylaxis. Now, prophylaxis means if a person is going in malaria endemic areas, then a person will be taking some medication in advance. So, obviously, this is a primary specific prevention, and the drug will depend upon that for how long the person is going to stay. Short stay can take tablet daily, like a doxycycline, to be started 1 to 2 days before. But if it is going to stay for a long time, cannot take a tablet daily, then has to be taking the tablet weekly. So chloroquine to be started 1 week before as 300 milligram per week. Mafloquine to be started 2 weeks before as 250. You can remember as a 2-2. 2 weeks before 250 milligram per week. But in all the three drugs, whether it's a doxy or chloroquine or the mefloquine the person is taking, and when the person is leaving that area, they had to take a drug, these drugs, for 4 more weeks. That is important, because suppose the day before leaving, if they had a mosquito bite, and they can develop the disease after the incubation period. Clear? So this is about the prophylaxis. Now we had a very important indicators of the national program. One is on annual parasite incidence, very important indicator. There's a API. No confusion with the ARI, annual rate of infection, that is an indicator of the tuberculosis program. So API is the annual parasite incidence, is the number of confirmed malaria cases per thousand population, and our goal is for elimination of the malaria is that API should be less than 1 in all the districts. The recent malaria transmission is suggested by the infant parasite rate. Annual blood examination should be minimum 10%. Okay, and the insecticidal agents what we are using, because along with the diagnosis and the treatment we have to deal with the vectors also. So we are doing the integrated vector management, and as we know that female anopheles after the blood meal it is resting inside, so we are doing the indoor residual spray in malaria. That is very important in, because in filariasis and other infections we are having the outdoor spray because mosquito is resting outside. So in malaria we are having the indoor residual spray. In urban areas we are mainly focusing on the anti-larval measures, because we had an artificial water collection or the water collection in these areas where the mosquitoes can breed, or in the areas where we are having the API of 5 or more we are using the long lasting insecticidal bed nets, and in the area with the API of 2 to 5 we are using the indoor residual spray with insecticide treated bed nets. And we are having the malaria scheme in the urban areas, and it is applicable in those areas with a population of 50,000 or more, and the main focus is on the anti-larval measures. So remember that in rural areas our main focus is on the adult mosquito control, and in the rural urban areas our main focus is on the control of larvae. And for the areas where we are having the urban malaria scheme, our slide positivity rate should be more than 5%. And the national framework says that we have to do the elimination of the malaria by 2030. So our API should be less than 1 in all the districts. And we are having the vaccine in trial phase, that is the Mosquirix, and it has been given permission by WHO also. And this is blocking the liver infiltration by the parasite, so further cycle is avoided. Now another condition we are having the, because of Culex mosquito, and this is filariasis. And we know that this is caused by the Vaucheria bronchophtha or Bugia malai, and that is causing the blockage of the lymphatic channel, and we are having the swelling in that particular area, whether it could be in the legs or in the scrotum or in the face. And that's why this disease is also called as a elephantiasis, like a legs are swollen like a feet of elephant. Now the most important test in this is the uh, membrane filtration test. So the most sensitive is the membrane filtration test, but yes, we are also doing the peripheral blood smear examination. So in malaria, the most sensitive is the peripheral blood smear, but in filariasis, it is the membrane filtration. Clear? And in filariasis, we are only preparing the thick slide. So here the same, the slide is prepared in the periphery, but it is checked at the primary health center. And the drug of choice for the treatment of filariasis, we are giving the triple drug therapy as an IDA, that is ivermectin, diethylcarbamazine, and albendazole. Now, ivermectin we are giving 150 to 200 microgram per kg single dose oral. Diethylcarbamazine it is given for 12 days as 6 milligram per kg per day, and albendazole it is given as 400 milligram single dose oral. And we are also giving the supportive treatment for lymphedema. Now, our goal is for elimination of filariasis, and this is by 2020. And for this elimination, we are giving the annual triple drug therapy covering to almost whole population, and if it not whole, at least to more than 80% of the population we are giving this annual triple drug therapy. And our purpose is to bring down the percentage of the individual with microfilaria, that is microfilariemia, to less than 1%. Okay, so if our microfilariemia percentage is less than 1%, then it will block the chain of transmission and will not have the new cases. That is what is elimination. Clear? And the dose is the same, that ivermectin 150 to 200 microgram. The diethyl carbamazine is 6 milligram per kg. Albendazole is 400 milligram single dose. But all three are being given as a single dose. And simultaneously, we have to do the vector control. But remember here, the Culex mosquito is sitting outside, so we are doing a outdoor fogging. While in malaria, we were doing a indoor residual spray, and as well as we are distributing the normal common salt which has been mixed with the diethyl carbamazine, so it is also killing the microfilarias. Then we are having another condition as uh, agent is the group B arbovirus as a dengue fever, and the various strains are, it is the dengue virus 1, 2, 3, 4. And the diseases caused by the group B arbovirus is the Japanese encephalitis, yellow fever, and the KFD, while the group A is arbovirus is causing the chikungunya. Then one more point is that if we had a infection with one strain today, we can have the infection with another strain in future. And if we are having the repeated infection with another strain, then the complications are more. So this infection is not giving us a क्रॉस प्रोटेक्शन. ओके, ऐसा नहीं है कि हमारे को आज एक वायरस स्ट्रेन से हो गया तो दूसरे से नहीं होगा. So one infection, it is not giving a cross protection with to the another strain. So we can have the repeated infection with another strain also. Now we can have either the simple viral fever, or we can have a dengue fever, dengue hemorrhagic fever, or we can have the dengue shock syndrome depending upon the severity. And the diagnosis can be done either by the viral isolation, or we can use the NS1 antigen test. We can do the hematocrit value, where we find that hematocrit is increased, the platelet count is decreasing, and we can elicit the uh, capillary fragility by doing the tourniquet test, or we can find the fluid in X-ray or ultrasound because of the extravasation of the fluid. So here the most important point in the treatment is that we have to maintain the blood volume, because if we are having hypovolemia, the person can go in a shock. So we have to maintain the blood volume giving the IV fluids. There is not a necessary to transfuse the platelets until unless they say that platelet count is dropping down up to the either 10,000 per cubic millimeter of the blood, or if there is an extensive bleeding, then there is no need to give the platelet transfusion. But yes, we have to keep the platelet ready, and in future whenever we are requiring, we can give. And we have to do the close monitoring of the patient to look for any bleeding externally or internally. But the most important point is the prevention, because we know that this is caused because of the Aedes mosquito, and Aedes mosquito is where they are breeding. They are breeding in an artificial water collection. So if we can avoid the artificial water collection, or we can change the water every week, because their extrinsic incubation period is around 2 weeks. So if we can change the water every a week, so we can avoid the conversion of these eggs into the adult mosquitoes, and we can prevent this condition. So this is your primordial level prevention, and the Delhi government has given a strategy as 10-10-10 to deal with this dengue fever. Means for 10 weeks, every Sunday at 10 a.m. for 10 minutes, we have to look for any artificial water collection near our houses, and we have to change that water. Or we can put some medication, like we had discussed that, because Aedes larvae, they are suspended to the surface, so we can put a temifos in a water. Now, for the parallel larvae of Anopheles, we have to put the Paris green dust. But those larvae who are suspended, we can put the temifos tablet in the water. This will be killing the Aedes larvae, Culex larvae, and the Mansonian larvae. Okay, and we are also having the vaccine under the trial phase, dengue vaccine. The point to remember here, the strain is CYD-TDP, that was asked in one exam, and whenever it has to be given, it is in the powdered form, so it has to be dissolved in the normal saline to be given by subcutaneous route, 3 doses at 6-month interval. So this was about your vector-borne diseases. Now, if we talk about various zoonotic diseases, the very important is the rabies. And rabies is caused by the Lysa virus, and especially the wild or the street virus, because the fixed virus we are using for vaccine preparation. Usually, the wild animals are the reservoir, and the saliva of the rabid animal is acting as a source. And how we can do the diagnosis? In a dead person or the dead animal, we are taking the brain biopsy and we can demonstrate the nigri bodies, that is, intracytoplasmic inclusion bodies, and best are seen in the uh, ammon horn of hippocampus as well as in the cerebellum. If the person is alive, then we can take a skin biopsy from the nape of the neck and we can demonstrate the viral antigen. And based on the bite, that whether it's only lick on the intact skin, it's a grade 1. We are only giving a local clear, means cleaning of the wound. And if there is a scratch or the nibbling, so in the grade 1, only the local clear cleaning and just reassurance, nothing is required. But in the grade 2, the scratch or the nibbling, but no blood is there, खून नहीं निकला है. In that case, again the local clear, just the cleaning, and we are giving the vaccine also. But if it is a grade 3 bite, that is a extensive bite, multiple lacerations, or it is a deep wound, or any lick on the mucous membrane, then it is coming as a grade 3 bite. In that case, we have to give the a local cleaning, local immunoglobulins also, as well as the systemic vaccine administration. So here the question is that what are the various points in the local care? If it is a simple no scratch, nothing, grade 1, we just wash. But if it is a scratch, we'll just wash again. But if it is a multiple lacerated wound, that along with the washing or cleaning with the running water, we are giving the local infiltration of the immunoglobulin. And if we find that some major wound is there, but we are not going to give the stitch for minimum 24 hours or 24 to 48 hours, okay, because this will facilitate the entry of the virus into the circulation, or shortens the incubation period. Now the next point is that how much immunoglobulin we are using. If you are using the human immunoglobulin, it is the 20 international units per kg, but if you are using the animal immunoglobulin, it is the 40 international units per kg. Clear? Now we are talking about the various schedules of the vaccination. Very, very important and asked in the examination. Then a vaccination schedule depends upon whether we are giving before the dog bite or animal bite, or we are giving after the animal bite. So if it is a pre-exposure prophylaxis, then the schedule is 0728, and here we are giving by the intramuscular route. And the purpose is to give the antibody titer of more than zero point 0.5 international units per ml. If you are giving after the bite of this rabid animal, then it depends upon whether the person had received previously or the person had not received the previous vaccine. So if the person is already vaccinated, then we are giving only the smaller doses. As if you are having a intradermal schedule, then 0 3, these are the days when we give, or the intradermal, these are the 4 site on the day 0. So intramuscular on the day 0 and day 3, and intradermal it is 4 site on day 0. Now if a question is asked that which schedule is preferred, then obviously the intradermal schedule is preferred because it is having the better antibody production and the lesser amount of the dose is required. But it requires the technical skill to administer the vaccine as intradermal. If the person is not skilled or the trained to give the intradermal, he can give the intramuscular also. And if a person is non-vaccinated, like general population, me and you, that had accidentally the bite, then we are going with this schedule. And in the Eastern regime, which is intramuscular, we are having the 0 3 7 14 28. These are the days when we are giving the vaccine. But if you are following the Zagreb regime, again intramuscular, but on the day 0, we are giving the double dose. So that's why it is written as a 2, means a double dose is given on the day 0, then nothing on the day 3, then day 7 the single dose, nothing on the day 14, day 28 single dose. That's why it is written as a 20101. Okay, so no confusion that it is not intradermal, it is intramuscular. Then if we are using a Thai Red Cross regime, it is intradermal, and we are giving as the 22202. 222 means here we are giving the two side of intradermal on the two shoulders and the day 0, then two sides on the day 3, two sides on the day 7, then no on the day 14, then two sides on the day 28. So that's why we are giving as an intradermal route, and here the number are representing the sides. Okay, so there should not be any confusion. So this was the vaccination schedule in freebies in vaccinated or non-vaccinated individuals as post-exposure prophylaxis or pre-exposure prophylaxis. Then another important disease is the Japanese encephalitis. And here the point to remember is it is again caused by the Culex mosquito, and it is the rice paddy fields, they favor the multiplication or the breeding of the Culex mosquitoes because they are breeding in a artificial this dirty water collection. These mosquitoes can fly up to a 9 to 11 kilometers. So if we are finding the Japanese encephalitis cases in one village, we have to look for a breeding sites in the nearby villages also. And here the pigs are acting as a amplifier, and cattle and buffaloes are as a mosquito attractant. And obviously this disease is being prevented by the vaccination, and now we are giving as the national program also in endemic areas. The two doses are given, one at 9 to 12 months, the second is at 1.5 years, and the live vaccine we are using with the strain of SA 1442. And simultaneously we have to do the control of mosquitoes, and I said that Culex is resting outside, so we have to do the outdoor fogging, in contrast to the malaria where we are doing the indoor residual spray. Then if we talk about the various rickettsial diseases, the very important we have to remember about their vectors. As we had discussed that three type of typhosis: epidemic by the louse, endemic by the flea, and the scrub is by the mite. And the one more point that in the scrub typhus we are having the ulcer covered with the black crust or the black scab that is called as an Asia. Okay, and another point is that in the Q fever, we don't had any skin lesion because here the main route of transmission is through the aerosol route. So the only rickettsial disease where we don't had any skin lesion or it is not transmitted by the rickettsia is the Q fever. Clear? And the drug of choice for the treatment and the prophylaxis is doxycycline. Now, if we talk about the plague and yellow fever, the point to remember is that yellow fever is by the group B arbovirus, and the vector is the Aedes mosquito, while in the plague the vector is the flea. And if they specifically ask the vector for the this pneumonic plague, then no vector because it is being transmitted through the aerosol route. And red flea is also known as a Xenopsilla chiopsis. Okay, the agent is Yersinia pestis, but the vector is a Xenopsilla chiopsis. Then important point is that if they talk about the incubation period of the plague, in general we say 2 to 7 days. But if they talk about the incubation period of the pneumonic plague, it is very short, 1 to 3 days only. And quarantine for yellow fever is 6 days. The incubation period is 2 to 6 days. Now the most dangerous type of the plague is the pneumonic, because once we do the spray, kill the flea, still it is transmitting. And the most common is the bubonic. We had enlarged lymph nodes also. And the drug of choice for the treatment of plague is the streptomycin injection, and for the prophylaxis we are giving tetracycline. While for the yellow fever only we have to give the supportive, because yellow means it is causing the jaundice affecting the liver, and that's why it is a yellow fever, means fever with the jaundice is there. And as routinely we are not giving the vaccine to our community, there is a possibility of 30 to 40% of mortalities in yellow fever. And the preventive vaccine for yellow fever with the strain is the 17D. It is a live vaccine. While for the plague prevention, we are using the killed type of the vaccine. Now, in addition to management, we are spraying the insecticidal agent to kill the vector as the flea. And for control of the plague, we had to bring down the red flea index to 0 within 48 hours. And what is red flea index means the number of the red flea per red. And we know that this plague is included under the IHR, that is International Health Regulation, along with the what other diseases we had in the International Health Regulation. We are having the yellow fever, cholera, and plague. Then we had strategy as eye strategy for a yellow fever, like an elimination of the yellow fever epidemic. We had a safe strategy and get strategy for the trachoma. We had an arm strategy, and the catch up keep up strategy follow up is for the measles. So remember the name of strategies. This is uh, arms strategy. Accelerated measles mortality reduction strategy. Accelerated measles mortality reduction strategy is the ARM strategy for measles. Then, if we talk about the leishmaniasis, the vector is the sandfly, very commonly asked with its image, and agent is the donovani for visceral, tropica for cutaneous, and brasiliensis for the mucocutaneous. Okay, and these sandfly, they can fly only up to the 6 feet high, and this was the question asked, that this is a disease of the low altitude, seeing maximum up to the 600-meter or the 2000 feet height. And the diagnostic peripheral test is the RK39 dipstick test, but confirmation is done by taking a biopsy from the either lymph nodes, from the liver, from the bone, or the skin lesion, and demonstrating the LD bodies. And in the LD bodies, we are having the non-flagellar form of the protozoa, that is the A mastigote form. Okay, and skin test, what we are doing to know the immune status, not for the diagnosis. Remember, the drug of choice for the treatment is the liposomal amphotericin B single infusion 10 milligram per kg. But for the post dermal leishmaniasis, we are preferring the miltefosine because it has to be given for a longer time. And simultaneously, we have to do the vector control. And still now, in some areas, it is responding to the DDT. So we'll take the DDT as a first choice, not for the mosquitoes, but for the sandfly control. But if it is not responding to the DDT, then we can have the malathion spray. And we are doing twice a year spray for the DDT because it is having a residual effect. And goal is the elimination of the disease by 2020, and ASHA workers are doing as active surveillance and trying to detect any suspicious cases of leishmaniasis. Then if we talk about the important points about brucellosis, KFD, or the leptospirosis, then the leptospirosis, the point to remember is the source is the urine of the infected animal. Okay, while in the brucellosis, they ask the source is the direct contact of the infected body secretions or the fluid, like milk, placenta, or the blood. And in the KFD, they ask usually the vector. That in India, the KFD, it is caused because of the hard tick, and outside it is caused because of the soft tick. Then the drug of choice for the treatment of brucellosis is doxycycline. Can be prevented by the live vaccine which we are giving to the female cattle and the farmers who are handling their babies. And for leptospirosis, we are having either the doxy or the penicillin as a treatment, and the doxy for the chemoprophylaxis. While in the brucellosis, we have to give the supportive treatment. Okay. In the brucellosis, we are giving the doxycycline, and in the cases of the KFD, it is a viral infection, we are giving them the supportive treatment. Then, if we talk about the echinococcosis, and the teniasis, the point to remember is echinococcosis is a dog tick-borne disease, and here the definitive host is the dog. Okay, this is the one point. And second is that the disease is causing the hydatid cyst, and they ask its location. So the most common site is the liver, one thing. And in the liver, it is the right lobe of the liver, and in the right side, it is the posterior superior lobe of right lobe of liver. Clear? And the drug of choice for the treatment is the mebendazole. Okay. And if we talk about teniasis, it is if it is related to the improperly cooked pork, then it is because of the Taenia solium, and improperly cooked beef, it is the Taenia saginata. And here, either the infection can be in the intestine as the teniasis, or we can have the cysticerca in the muscles, or we can have the neurocysticercosis. Now, for the neurocysticercosis, the drug of choice for the treatment is we are giving the steroids, along with the albendazole, because albendazole is crossing the blood-brain barrier. But if it is the teniasis or the cysticercosis, our drug of choice is the praziquantel or the niclosamide. The one practical point is, if you are dealing with the teniasis, now along with this praziquantel, we have to give the laxatives, because with this they are getting irritated and they can further penetrate the intestinal mucosal lining. So with the purgatives, they are just being flushed outside. Then a few points about the Nipah virus. They had mainly asked about the mode of transmission. So either it is because of direct contact with the either infected bat, pigs, or the infected human beings, or by consumption of the fruits or the vegetables which has been contaminated by the bat secretions or the excretions. And this is a viral infection having high mortalities up to 75%, but we only have to give the supportive treatment. So these are the a few important zoonotic diseases. Now, if we discuss about the various respiratory group of the disorders, the one very important is measles infection or the rubella. And here the question they ask is the incubation period 10 to 14 days. The period of communicability is the 4 days before the rash to 5 days after the rash. And highly infectious with a secondary attack rate of more than 90%. We don't have the subclinical cases of carriers, only the case of the measles can transmit the infection. Then important point is that we are having the Koplik spots. So point to remember is that Koplik spots are seen in the measles. Where they are found in the buccal mucosa opposite the molar teeth, second molar teeth, and the third is they are seen before the measles eruptions or the pre-eruptive phase. That is very important. And if you see the characteristic of a measles rashes, then measles rash is usually starts behind the ear, coming on the face, going to the chest, and they are highly confluent. That maculopapular rashes are there, and red rashes are there, and they are more confluent and concentrated, especially on the central part of the body. And the complications we can have commonly because of the secondary bacterial infection, we can have the most common infection as an otitis media or pneumonia, or the child can have diarrhea. And because of the diarrhea, the child is showing the vitamin A deficiency manifestations. And the rarest complication is the subacute sclerosing panencephalitis. And we all know that treatment is supportive, but yes, the prevention is possible. And here the question they ask is, the one is routine vaccination, what we are giving to our child, and the second is the post exposure vaccination. This is the point. The pre-exposure, we all know that we are giving as a measles vaccination routinely, the live vaccine, the 2 doses at 9 to 12 months and 1.5 year as the MR or the MMR vaccine. And it is given in the left deltoid, sorry, left method BCG hai, it is given in the right deltoid, and it is given as subcutaneous and 0.5 ml. Clear? And if a child has been exposed to a measles infected child, and within the 3 days of an infection or contact, if we can give the vaccine, yes, good amount of antibodies can be there and it can be prevented, because the incubation period lowest is the 10 days. So within the 3 days of infection or contact, if we are giving the vaccine, then within the next 7 days, the good amount of antibodies are formed and it can protect the child. So this is important, that post exposure, within the 3 days of an exposure, we have to give the measles vaccine, or if a baby is immunocompromised, we can go with immunoglobulins. Now the very important point is that what are the strategies for elimination, that our goal is the elimination of the disease by 2020, and criteria is that the incidence of the disease should be less than 1 per 1 million. Then we are having the two strategies. One is the catch up, keep up, and the follow up strategy. And here we are giving the vaccine to the 9 month to the 14-year-old child. Normally we are giving the vaccine till 5 years, but in this strategy we are including the children between the 9 months to 14 years. 1 point. Then we are having the accelerated measles mortality reduction strategy. And here we are giving the 2 doses of the vaccine, and the coverage should be more than 80% if we talk about individually district, and more than 90% if we talk about nationally. So these are the preventive strategies of measles. Now, another important disease is chicken pox, and the point they ask is the incubation period is 14 to 16 days, and secondary attack rate is more than 90%, again highly infectious, and the period of communicability is 2 days before to 5 days after the rash. Measles में 4 days before to 5 days after, and यहाँ पे 2 to 5. Okay, 2 days before to 5 days after the rash. And we are having the typical characteristic of a rash. This is asked in an image based question also, that it is having the centripetal distribution, means more on the central area. These are pleomorphic, that all the varieties of the rashes we can have, and the crust are non-infective. Okay, and we know that treatment guideline, it is only the supportive, but yes, we can have the prevention by giving the vaccine. But remember one point, that this chickenpox vaccine is not included in our national program. So those who can afford, they can give this vaccine to their children. The 2 doses we are giving, and first dose at 1 year of the age, second is in the preschool age 4 to 5 years. It is given subcutaneous. And one more important point is that if a pregnant woman is in the family, and she is being exposed to a case of a varicella zoster, in that case, then we have to give the immunoglobulins. But before giving the immunoglobulins, we have to check for the antibodies in that lady. If the antibodies are already present, means she is immunized or she is already infected, then there is no need to give the immunoglobulins. But if she is having no immunoglobulins, means she is susceptible, in that case we can give the varicella zoster immunoglobulins. And the highest chances of the congenital malformations are seen between the 13 weeks to the 20 weeks of pregnancy. Unlike rubella, the maximum chances of the congenital malformation are seen in a pregnancy less than 12 weeks of gestation. Clear? And if the mother is having the varicella zoster infection 5 days before to 2 days after the delivery, in that duration, because there is a possibility of transfer of infection from the mother to the baby during the delivery, then we have to give the varicella zoster immunoglobulin to newborn also. Now, if we talk about rubella, very commonly they ask about the congenital malformations or the congenital rubella syndrome. Now, if a mother is having the congenital, this antenatal infection, as I said, in the less than 12 weeks of gestation, then there is a possibility of congenital malformations in the baby born with the congenital cataract, or there could be the congenital deafness, and the congenital heart disease mainly is the patent ductus arteriosus. So commonly they ask this question, and here the rash is less concentrated, like unlike the measles, because measles may it is highly concentrated confluent rashes are there, but यहाँ पे it is very less, and this disappears within the 2 to 3 days. And the again important point is the prevention. Routinely we are giving the rubella vaccine as per our national guideline, but very important they ask is that how you are going to prevent the infection in the pregnant woman who has been exposed to rubella case. So again, in that case, you have to check for the IgG immunoglobulins in the pregnant woman. And if in the pregnant woman we find that IgG immunoglobulins are present, in that case means they are immune, because immunoglobulins are present, then there is no need to give the immunoglobulins. But if the IgG immunoglobulins are absent in that pregnant woman, then we are giving the rubella immunoglobulins in the dose of 20 ml straightforward, because it is not related to the kilograms. 20 ml we are giving to the pregnant woman. And another point now we are following, that we are doing the screening of the young married couples who come to the clinic and they say, doctor, we want some investigations because we want to plan our baby. So in that case, we are doing the screening for a rubella infection. So we are doing their IgG antibodies, and if the IgG antibodies are present in that lady, it means either she had received the vaccination or she had been infected in the past, so she is safe and she can go with the pregnancy. But if the IgG immunoglobulin is not present, it means either she had not received the vaccine, or she has not had an infection in the past also, she is susceptible. So first we'll give the vaccine and then tell her to avoid the pregnancy for minimum 1 month, and after that she can plan for the baby. And this is to avoid the congenital malformations happening because of the rubella infection in the first trimester. Okay, then another important point is about influenza. Now, we all know that very short incubation period of around 18 hours to 72 hours, and very commonly it is because of the type A influenza virus, and where we are having the strain as H1N1 or H3 and 2, and type B influenza virus as Victoria and Yamagata strain. That's why now in the tetravalent vaccine we are having the strain of all these four. Then based on the symptoms, we can have the three categories of the patient: A, B, and C. The A are uncomplicated, B are having the complications as pneumonia, and C are progressive with multi-organ failure. And these are the groups which we have to hospitalize, and we have to give the extensive treatment, because these are most dangerous cases. As we all know that influenza virus is changing their strains very quickly, and this is because of the shift or drift phenomena. Sudden change is the shift, and this is because of the genetic recombination or the rearrangement, or there could be the gradual as the drift because of the point mutation. And the drug of choice is oseltamivir or Tamiflu. No confusion, Tamifos we were using to kill the larvas, and this is Tamiflu. You can remember, as influenza we commonly call as a flu, so this is Tamiflu. Now, very commonly they ask about the doses in weight groups. Okay, so adult dose normal is around 75 milligram twice a day, and this is given for 5 days. But the dose is less if a weight is less. Between the 24 to 39 kgs, it is 60 milligram. 15 to 23 kgs 45, less than 15 kgs 30 milligram, and for the infant less than 3 months is 12 milligram, 3 to 6 months 20 milligram, and 6 to 11 months is 25 milligram. And for the prevention, the dose is the same, but it is given once a day, and the duration is 10 days. Okay, so for the treatment, twice a day for 5 days. For the prophylaxis, it is once a day for 10 days. The drug is same, oseltamivir, and the dose is also same as per the weight. Then prevention is possible by the vaccine, and the point to remember is that live vaccine is given through the nasal route. This is very important, and the killed is given intramuscular, and the live is quadrivalent, and the killed is either the monovalent. Now we are also having the quadrivalent strain in the vaccine of killed. Obviously, the monovalent is cheaper in comparison to the quadrivalent strain. So this was about your influenza. Now, another disease is meningococcal meningitis. We know that it is highly fatal, and if it is being diagnosed early, then yes, the case fatality can be reduced. So, the purpose is the early diagnosis. The main is the prevention. If we are not able to prevent, then we have to do the early diagnosis. And the serotypes responsible for meningococcal meningitis is the A, B, C, W135, and Y. And it is said that the B strain is non-immunogenic because it is not able to produce the antibodies, but now we are having the various combined preparations, so we are having the vaccine for the B strain also separately. Otherwise, normally we are having the quadrivalent strain, so they commonly ask which strain we had a vaccine. So it is A, C, W135, and Y. Okay. Then the point is that how we are doing their diagnosis. If a person is coming with the history of fever, meningeal irritation, or some unconsciousness, and when we examine, we find the neck stiffness is there, and we are doing the CSF examination, and we are demonstrating the Neisseria, gonorrhea organisms in that. Okay, then the point is how we are going to treat. So in the, sorry, not a Neisseria gonorrhea, we are demonstrating the Neisseria meningitis group of organism, that is a gram-negative diplococci. And once we diagnose, we are treating with the antibiotic, and the drug of choice for the treatment is penicillin for meningitis, Neisseria meningitis group of organism. But in general, if they say that what is the drug of choice for the meningitis, it is the ceftriaxone or the third generation cephalosporins. But for the Neisseria group of organisms, it is the penicillin is the drug of choice. Now we have to treat the carriers also, and in the carriers we are also giving either the rifampicin or ciprofloxacin or ceftriaxone. Now another important point is that how to prevent the exposed close contacts. Now, suppose if a person in the family has been diagnosed with the Neisseria meningitis infection, so to the close contacts, not the family members, it could be the friend also, some neighbors also. So, to the close contacts, we have to give either the rifampicin or ciprofloxacin, but commonly they ask in the pregnancy, if a pregnant woman is there, had been exposed to infection, in that case, we are giving them the injection ceftriaxone, third generation cephalosporins. And we are having the vaccine also, that is a meningococcal polysaccharide vaccine. And the important point is that here we can have the mass vaccination also, because this disease is having the very high case fatality rate. So if we had an epidemic of the meningococcal meningitis in any area, we can give the mass vaccination to the community. Now, if we talk about diphtheria and pertussis, then in the diphtheria we are having the high number of the subclinical cases and carriers. Carriers are much more higher, and these are responsible for all the cases of new transmission. And in this we are having the swelling in the neck, bull neck appearance is seen, while in pertussis it is because of the Bordetella pertussis group of organism. And here the child is having the paroxysm of the cough, and there is a inspiratory crow. Inspiratory crow like a sound is there. And the drug of choice, commonly they ask, so in the pertussis, the drug of choice for the cases is erythromycin. As we don't had any carriers, so we don't had any drug for carriers in pertussis. But yes, for the diphtheria, the cases, we have to give the penicillin along with the antitoxin. So remember, in any disease where the role of toxin is there, like in diphtheria, in the tetanus or the botulism, we have to give the antitoxins. So penicillin and antitoxin, and for the carriers, we are giving the erythromycin. Now, those who are coming in close contact, means any sibling and a child in the family. So if a diphtheria case is in the family and there's another child in the family, and if that child, if it is immunized and had received the booster or the primary dose within the previous 2 years, then no action is required. But if the child had received the booster or the primary dose more than 2 years back, then definitely the antibody titer will be less. In that case, we are giving the booster dose of diphtheria to that child. Okay, but if the child is non-immunized at all, not received the vaccine earlier, in that case we are giving the penicillin as well as the antitoxin and the complete course of the vaccine. While in cases of pertussis infection, if the child has been exposed, so either we are giving the chemoprophylaxis as erythromycin, or sometimes they say that if a mother is going to deliver a baby, and in that case what happens that we are giving the DPT vaccine to a newborn baby at 6 weeks. So within the first 6 weeks, this baby is susceptible to have the infection, and from where it can have the infection from the other sibling of the family. So what we do, we'll give the either the booster dose to the sibling in the family, so he cannot have the infection and he cannot transfer the infection to this newborn, or we can give the Tdap injection to the mother after 30 weeks of the gestation. So the mother will have the antibodies in their circulation, and through the placenta, mother can transfer the antibodies to the baby. So it will protect the baby for first 6 weeks of life. So this is how we are having the management of close contact. And we all know that prevention is by the DPT vaccine, which is a combined vaccine, the 5 total doses, 3 primary and the 2 booster doses we are giving. Then, if we talk about the mumps may, the very commonly they ask about the complication, and in the children we can have pancreatitis, and in the post-pubertal age or adults we can have the ophritis or orchitis depending on the either the female or the male child, and it is usually unilateral. And in any age group we can have encephalitis also. Okay, then. Prevention is by MMR vaccine, and it is same like we had discussed in the measles. Then if we talk about the various pneumonias, now pneumonia as such is not a disease, but it is a manifestation of the certain other conditions. Okay, so what is our goal in relation for pneumonia as well as the diarrhea? So they say that goal for 2025 is that we have to decrease the mortality because of pneumonia in the children less than 5 year is the less than 3 per 1,000 live births, and in the diarrhea cases should be less than 1 per 1,000 live births. So we should try to decrease the deaths because of pneumonia and the diarrhea, as well as simultaneously we have to decrease the incidence of severe pneumonia by 75% and the severe diarrhea by 75% by 2025, and the base level is whatever the value of 2010. Now, the important point is that how you are classifying the patient in the various categories of the pneumonia based on the clinical features, because here we have to classify as per the IMNCI guidelines, and the multipurpose worker male has to decide that which child to be kept in the village or at home treated there, or which child needs a immediate referral to the higher centers. So timely treatment can be given and we can save the life of the child. So the parameters what we are taking in a consideration is the respiratory rate and symptoms of upper respiratory tract infections, and what are the condition of the intercostal muscle involvements, or any feature of the shock is there. So before classifying we should be knowing that what is the normal respiratory rate, because as per the age the respiratory rate changes. Okay, so if we say that in a child of 0 to 2 month of the age, the respiratory rate up to 60 per minute is considered as normal. Between the 2 to 12 months, respiratory rate up to 50 is considered as normal, and the respiratory rate up to 40 after 1 year of the child is considered as normal. So we have to read the question very carefully. What is the age of the baby? What is the respiratory rate? Because it changes with the age. So if I say that respiratory rate is a normal, in that case it is a no pneumonia stage, means the lungs are not involved, and only the features of upper respiratory tract manifestations are there, and that is a no pneumonia stage. But in the pneumonia there is a increased respiratory rate. Obviously the features of upper respiratory tract involvement will be there, but there is no involvement of the accessory respiratory muscles or features of hypoxia, because the patient is stable. But if it is a case of severe pneumonia or the very severe pneumonia, in the severe pneumonia along with the increased respiratory rate, signs and symptoms of upper respiratory tract manifestation, there is air hunger, so involvement of the accessory respiratory muscles like a flaring up of the nostrils or indrawing of intercostal spaces. And if it is present along with the features of the shock, then it is in the very severe pneumonia. Clear? So the categories under the IMNCI, the no pneumonia is a green category, can be treated at home. Actually the no treatment as such is required except only the management of upper respiratory tract manifestations, while pneumonia stage it is a yellow category and we have to give the antibiotics and we have to do the follow-up. If they are responding, improving, then continue the treatment, but no response, then we have to refer to the higher center. But if it is the pink category, in the severe and very severe pneumonia, we have to give the pre-referral antibiotic like an ampicenta we are giving and referring the child to the higher centers. So this is about your pneumonia management. Many times a clinical case scenario they give, and we have to identify whether this is a case of no pneumonia, pneumonia, or it is a very severe pneumonia or a severe pneumonia. Okay, so okay, here we take a break of 10 minutes, and then we'll discuss remaining diseases. So the time by my watch is 6:28. So we'll restart at 6:40. Hello friends, welcome back. Now we will be discussing about a few more respiratory diseases, and one important respiratory disease is tuberculosis. Now, if we talk about the tuberculosis, we know that important test for the diagnosis is now the sputum examination, and the guidance is that we have to do the x-ray along with the sputum examination. Okay, but still if you have to choose the one, the most important is the sputum examination. And the point to remember is that here we are having the two sputum smear examination. One is the spot sample and the another is the next day morning sample. And if any one of these two it is positive for the tubercle bacilli, we report that patient as a smear positive. There is no necessary that both the tests should be positive, one thing. Now, second is that where we can collect this specimen, either this can be collected at home as a part of active surveillance and it is transferred to the DMC center where it is being checked, or as a passive collection if a patient is coming to the health center. Now, slides can be preferred in the periphery, but they are checked at the DMC, that is the designated microscopy center infrastructure for the tuberculosis program. And they are located at a population of the 1 per 1 lakh in the plain area, roughly at a level of the community health centers, or it is 1 per 50,000 in the hilly or the tribal areas. Now, from here, the slides are sent to the tuberculosis unit, and there they are rechecking all the positive smears, and it is covering a population of the 1.5 to 2.5 lakh in the plain area, and in the hilly or the tribal area it is 1 per 1 lakh population, as well as it is checking the randomly the 10% of the negative smears. So this is very important point. Now, another point is that if we had any doubt, either we are not able to detect the bacilli, or person is having the symptoms suggestive of the tuberculosis, or even if we had detected the tubercle bacilli, to look for the rifampicin sensitivity, we are going for the CB-NAT test. So CB-NAT test is again a very important test, that is a nucleic acid amplification test, and this is to detect the bacteria in those cases who are suspicious and sputum is negative, or it is to look for the rifampicin sensitivity to decide whether they are the category 1 patient or the category 2 or the 4 and 5 category patients, and we have to give the treatment accordingly. Either we can have the cartridge based NAT test, that is a CB-NAT, or we can have the this a true NAT based, which is a non cartridge based test. Then if you want to do the diagnosis of the latent tuberculosis infection, then it can be done either by the tuberculin skin test, or we can do by the IGRA test. And now in this program, we are having the case finding as an active finding. Active surveillance means the health worker is going to the patient house. Passive, the patient is going to the health center. And the intensified means we are combining the program with other national program. Like if a patient is coming with any STD infection, then we are checking for the tuberculosis, like that. So more than two national programs are being combined. Then the next point is that who are having the suspicion of having tuberculosis. If we are having the fever for more than 2 weeks, lasting for a cough more than 2 weeks, or the weight loss of more than 10%, night sweats, we can have the palpitation, hemoptysis, or the abnormal chest X-ray. Or in the pediatric age group, if they had seen no growth or no weight gain in the past 3 months, or they are losing the weight of 5% or more in the last 3 months, along with the history of the fever and cough for more than 2 weeks, or there is a history of contact with any tuberculosis case, could be a suspected case of pediatric tuberculosis. And as we know that algorithm says in the tuberculosis case that we have to do the sputum smear as the X-ray both, and if we are able to detect the bacilli, then we call that as a smear positive case. And in that case, if it is suspicious, we are for resistance, we are going for the CB-NAT, or we are doing a CB-NAT in those individuals also who are not having the bacilli in the sputum, but they are having the clinical suspicion. And then based on the cbnat test, then we are trying to detect the mycobacteria and trying to detect the rifampicin sensitivity, and then we have to decide that how we have to proceed for the treatment. Now the patients are divided into the four categories. The category one is the new cases of pulmonary tuberculosis or extrapulmonary tuberculosis. The failure or the relapse of the defaulters are in the category 2. Failure means they had taken a complete course earlier, and failure are that who are on the treatment but not responding, means smear it is not coming negative, or once it is negative again becoming positive. Or the relapse means they had already taken the treatment and now again showing the symptoms, and the defaulters are leke bhag gaya, like a Nirav Modi or the Vijay Malia type, that they had taken a treatment for more than 1 month but not more than 2 months, between 1 to 2 months. These are the defaulters, means they are not coming for the follow. Then we had a category 4. Now you might be thinking that where is category 3? Category 3 has already been merged into the category 1. Now category 4 are the MDR cases or the DOTS plus cases, multi-drug resistant cases who are resistant to the rifampicin, isoniazid. This is the primary drugs, and we are giving them the second line drugs. But XDR cases are the category 5 or the extensive drug resistant cases who are resistant to the baseline category 1 drugs, rifampicin and INH, and the second line drugs as quinolone and any one of the injectable second line as kanamycin or the capreomycin. Then we are giving the daily DOTS regime. In the category 1, remember, its duration is 6 months or the 2 plus 4. And the 2 months we are giving the 4 drugs, HRZD, and for the 4 months we are giving the 3 drugs. In the category 2, if they are resistant to the rifampicin, we are treating like an MDR or XDR. If they are sensitive to the rifampicin, we are treating like in category 1. In the MDR and XDR cases, we are giving the extensive drugs, and for a duration of around 24 to 27 months in the MDR cases. And if the short MDR course, we are giving the higher number of the drugs, we are giving for 9 to 11 months. And in the XDR cases, the duration is around 24 to 30 months. And all these drugs, what we are choosing is based on the sensitivity reaction. Then the newer drugs has been added in the program as the bedaquiline and the delaminate. Mainly in the XDR cases we are using, and they are decreasing the sputum conversion time. The normal sputum conversion from the positive to the negative, remember, it is the 3 weeks time. But in the MDR and XDR, it may be taking long time. So during that time, they are affecting the other individuals, and that's why we are giving these drugs. So sputum become negative. Now they are not infectious to the community. Then follow-up, again it is asked that in the category 1 we are doing the follow-up of sputum at 2, 4 and 6 months of the therapy. And in the category 4 and 5, first sample we are taking after the 3 months, and then every month till the end of the intensive phase, and in the continuation phase every 3 months till end of the therapy. Now in the tuberculosis program, we had an FDC combination, fixed dose or combination therapy. This is used in the HIV treatment also, and here we are giving the single tablet having the 4 drugs in that, and number of the tablets will be decided as per the body weight of the person. And for children, we are having the 6 groups, or the 6 weight bands are there, and in the adults we are having the 4 weight bands are there. And the red color kit is given for the category 1 treatment of tuberculosis. Then we are having another software, that is the Niksha portal, and this is IT based software where we are having the details of each and every tuberculosis patient. Then no confusion with the Nishche. Nishche is a urine pregnancy test kit, and Niksha is the software of tuberculosis. And from the private sector, we have to report to the district hospital every month. And we are having the another very important scheme, that is the Niksha Poshan Yojana. Here 500 rupees per month is given to each and every patient of the tuberculosis throughout the whole course of a treatment. We are having the DOTS 99 ICT based adherence support system. This is for tracking of the person whether they are taking the tablets regularly or not. Then in the newborn, to protect from the mother, we are giving them the isoniazid for 3 months, and then we do the Montauk's test, and then we will decide. Another important point is, if we had been diagnosed the tuberculosis with the HIV infection, very commonly they ask that what to do. That first we have to start the ATT for 2 to 4 weeks, and then we will start the ART along with ATT. So never start the ART first, otherwise this will lead to the flaring of the symptoms, because immunity increases and flaring up of our symptoms. So to avoid the immune reconstitution inflammatory syndrome IRIS, we are giving first ATT, and then after 2 to 4 weeks ATT with ART has to be given. And another point is that all the people who are living with HIV, we are giving them INH as a prophylaxis to avoid the tuberculosis as an opportunistic infection. So these are the important points about the tuberculosis we have to remember. And one more point is the indicators of the tuberculosis program is ARI. No confusion with the API. API was annual parasite incidence was a malaria indicator, and ARI is the annual rate of infection. This is in relation to the tuberculosis, and 1% ERI means in future the 50 individuals will come up as a sputum positive smear per 1 lakh population. Okay, so this is your indicator, and the goal is that we have to make the India free from tuberculosis by 2025. This is for the Indian goal, and the global goal is that we have to make a globe free from tuberculosis epidemic by 2035. So in India, we are planning to have the elimination of the disease by 2025, and we are following a strategy of 90 90 90, means 90% of the individuals we have to detect, and those detected 90% should get the treatment, and those who are taking the treatment 90% should have the complete cure. Okay, so this is all about tuberculosis, very common infection and commonly asked in the examination. Now another very important condition, and the world is facing this pandemic for almost going to be 2 years within 1.5 months, that is COVID infection. And point to remember about the COVID infection is that it is in a pandemic state, and the SARS-CoV-2 virus is there, and high number of the subclinical cases and carriers are there, and we are having the incubation period of 2 to 14 days. Quarantine is 14 days, and the most important route of transmission is the droplets, not by the nuclei, remember, and they are falling till 5 feet. That's why we are having the social distancing of 6 feet is recommended. The secondary attack rate highly infectious, up to 30 to 40%. Fatality rate is 3.4, average ranging from 2 to 10% based on the comorbid conditions. Now if we talk about the various epidemiological point, the first reported cases of pneumonia of unknown origin to the WHO China office was on 31st of the December 2019, and 30th of the January 2020 the first case in India was reported in Kerala, and the WHO has declared this as a public health emergency of the international concern. Then in March 11th, and the global pandemic was declared, and the next day on the 12th of March India has declared the national emergency. And the 1st of January 2021, we had government has given the permission of the emergency use of Covishield, and after 48 hours, the permission of use of Covaxin was also given. And we had started our vaccination drive from the 16th January 2021 onwards. And initially, we had given the vaccine to the healthcare workers, frontline workers. Then it was started to the individuals beyond 50 years. Then it was started to the individual between the 18 to 50 years, and then now it has been given to the pregnant women also, to the lactating women also, and soon we are waiting for the permission of the vaccine to be given to the children. Although the drug controller office has been given the permission, but yet the government has to approve this protocol that we can give the vaccine to the children also. And we all know that India has crossed the mark of 1 billion vaccination in our community. Then if we talk about the diagnosis is best is by the RT-PCR test, and we can have the RAT test, that is rapid antigen test, or we can have the antibody detection test also. Now, who are considered as the person for testing for COVID infection? That all the symptomatic individuals or those who are having the international traveling history, or they are the symptomatic contacts of the lab confirmed case, or symptomatic healthcare workers, or all the asymptomatic high risk contact of the confirmed case. That is again very important. And all the patients of the severe respiratory illnesses. So who are considered as the high risk contact of this infection? The high risk contact, we say that those individuals that who are in the living in close proximity of the affected case, that within the 3 feet distance, or who had touched the patient without the PPE kit, and who had handled their clothes, who had handled their utensils, or who had traveled with the person with the distance of less than 3 feet duration. They are the high risk individuals. And if a one person is tested to be positive, so these high risk individuals to be screened out, and that is what is the sentinel surveillance we are doing. Suppose in the family the one person is tested positive, then we are testing all other family members to detect the other carrier cases or the subclinical cases, and this is to prevent the transmission of an infection to the community. Then we are having the three type of health centers to give the care to these patients. The one is the COVID care centers. This is for the mild cases and very mild cases of COVID infection who had the saturation count of 95% or more with the normal respiratory rate. Then we had a dedicated COVID health centers. These are for the moderate cases with a saturation of 90 to 94% with a respiratory rate little bit fast between 15 to 30 beats per minute. And we are having the dedicated COVID hospitals, and these are for the high risk cases with ICU facilities with the saturation of less than 90% or the respiratory rate of more than 30 per minute. Then for prevention, we had personal prophylactic measures, and in the personal prophylactic measures, we have to use the N99 or N95 mask. Then we have to regularly wash our hands with soap and water, minimum for 20 seconds. We have to frequently sanitize our hands containing the 70% alcohol mostly in all the sanitizers, and we have to cough or sneeze on our bent elbow, so not on the face, and we are not going to touch our face with the infected hands before washing, because there is a possibility of transmission of the infection through the nose, mouth, or the eyes, and we will be using the PPE kit. Then we have to take the environmental measures also, frequently cleaning the surface of the articles with the 1% sodium hypochlorite. So remember, for hand disinfection, it should contain the 70% alcohol, and for the surface disinfection, we are using the hypo solution, what in the layman term we are saying it is actually a 1% sodium hypochlorite solution. And we have to avoid the handshake. We have to say the namaste, or now they had made a modified way of handshaking, then they are doing like this. Okay, then there should be the good ventilation to dilute the virus, and we can have social measures also, and the social measure is that we have to maintain the social distancing of minimum 6 feet. So this is your primary level prevention health promotion. Okay, so we can have all the different levels of prevention. There is no primordial level prevention, but yes, we can have primary, secondary, or the tertiary level prevention. Now the various activities, if we talk about the lockdown we had, that was a primary health promotion. The vaccine we are giving, it is a primary specific prevention. Chemoprophylaxis we are giving, it is a primary specific prevention. The role of BCG vaccine, earlier it was said that in the beginning that if you are giving the BCG vaccine, it is giving a counter protection, but now it is not proved. But if it was giving, that again it was a primary specific prevention. Then we are disposing this biomedical waste, and the biomedical waste guideline is same as the general waste, with this few modification that we have to just label the bag that it is containing the COVID waste. One thing that we have to use the double layered bag. Third point is that we have to spray these bags from outside and inside with the 1% hypochlorite solution, as well as we have to spray on the trolleys vehicle which are taking this waste. And the guideline is same as the yellow bag is containing those which we are not recycling is the infectious waste. The red, it is containing all the plastic infectious waste, and the sharp is going in white, and glass material, it is going in blue. So it is the same, but in addition, these special precautions we have to take. And now we are giving the vaccines, and there is some myth about the vaccines, that uh, to whom we have to give, and what are the efficacy of the vaccines. Then five vaccines are available in the market, and throughout the globe, and we are administering. And before that, we can go with the dead body management, because that was also crucial in the second wave, when we had in very high mortalities. And they say that we have to plug the oral and the nasal orifices, and to avoid the body leak, because up till 24 to 48 hours, it is seen that the viruses are seen in the secretions. So body is packed in the leak proof plastic bag, and this is to be disinfected with a 1% sodium hypochlorite solution. No preservation is permitted, no autopsy was permitted. And when family members had to see the face for the last rituals, they are unzipping the bag, looking the face, and then again this is zipped out. And no hugging, kissing, or the bathing is allowed, and COVID appropriate behavior by the staff is being used. Then if we talk about the various type of the vaccines, we are having either the whole virus vaccine, mainly the kill vaccine, as the Covaxin, or we can have the protein subunit vaccine that is still under trial, is the Novavax vaccine, or the viral vector vaccine. It is using the adenovirus, and we had a Covishield or the Sputnik 5, or the messenger RNA vaccines, that is the Moderna or the BioNTech vaccine. Now, if we talk about the contraindications of the vaccine, that recently only the contraindication is right now is children less than 18 years, but I think within few days it is also out, because government is planning to give the permission to vaccinate our children between 2 to 18 years. Let us wait for the guidelines. Then only contraindication left is if there is a hypersensitivity to the previous dose of the vaccine. Okay. Earlier we used to say that in the pregnancy, in the lactation, but now all are permitted, because the information is changing time to time. So after every 1 month or 2 months, we take a glass, and then again we have to change the few protocols, and we have to add some new points in that. Now, if we talk about the side effects of the vaccine, the minor side effects at the site of the injection, we can have like a pain, redness, or the person can have a signs and symptoms of viral infections, and the rare is the demyelinating disorders. Now, there are so many myths moving with the vaccination, that till now the Indian government has not permitted the mixing of the brands, although the study is going on. And let us see the complete report. Now, the vaccine can be given in the presence of the comorbid diseases. The vaccine can be given to a patient of asthma. Vaccine can be given with the blood thinners. Vaccine can be given with the patients of allergy, provided that not allergy to the previous dose of the vaccine. Okay, and if there is an allergy to the previous dose, then definitely it is not to be given. Then another important point is that if you want to donate the blood after 14 days of the vaccination or recovery, we can give, or 4 to 8 weeks after the recovery with the comorbid diseases, the gap of 14 days between the other vaccines, and after the vaccination, the 30-minute monitoring is required. Then, in the menstruation, in lactation, yes, it can be given. And very important controversial point is that which is the best brand. They say that all the brands are almost the same with a minimal difference in their efficacy, but whatever the brand is available, we had taken, because like beggars are not the choosers at that time. When that personally, I had taken the vaccine in the beginning, in the month of January 2021, when this vaccination was started. And at that time only the COVID shield was available, so I had received both the doses of the COVID shield at a gap of 4 weeks, because at that time we were being given the vaccine at 4 weeks. Later on, the gap was increased to the 6 weeks, and currently it is a 3-month gap. And we can receive the vaccine. Those who had not received the vaccine and they had a COVID infection, they can receive the vaccine 3 months after the recovery, or if they had received the antibodies for their treatment, again after the 3 months of this antibody administration or immunoglobulin administration, they can take the vaccine. Then if we see the comparative table of all the different type of vaccines which are available in the market, the Covishield is developed by AstraZeneca and the Serum Institute of India. It's a viral vector vaccine, and we are giving the two doses stored at +2 to +8, and efficacy is around 70%. Then Covaxin is also stored at +2 to +8. It is a kill type of the vaccine. And Sputnik is also stored at +2 to +8. It is again a viral vector vaccine. And in the Sputnik, the gap is 3 weeks. And the same is in the Pfizer, Biotech, Moderna. The Pfizer and BioNTech, again, the gap is 3 weeks, while in the Moderna and Covaxin, Covishield, the gap is for the 4 weeks. The only problem with the Moderna and the Pfizer vaccine, although they are having the very high efficacy up to the 95%, that their storage temperature is very low, less than -20 degrees centigrade. While the Sputnik, which is also having the efficacy of more than 90%, but can be stored at +2 to +8 degree centigrade. And we had a special app designed by the government as a COVID app. This is to track all the individuals about the COVID vaccination. Toll-free number as 1075, and we had an Arogya Setu app, and this is to know that how many infected individuals are around you, and you can submit your health status, and this is a self-reporting of the condition. So this is all about your COVID infection. Then another important group of the disease what we will be discussing is the surface infections, sexually transmitted infections, and the intestinal infections. So now we'll be starting with the next group of infection, that is the intestinal infections. We know that the manifestation of the intestinal infection is diarrhea, and we know that if you are managing the diarrhea either by the oral fluid or the IV fluids, 90% of the mortalities can be prevented. So very commonly they ask about the composition of diarrhea, and the total osmolarity of this diarrheal fluid is 245 millimole, with the sodium and the glucose as 75 millimole, potassium as 20, chloride 65, and citrate as 10. If we see the weight of the sachet is 20.5 gram. Now the dose of ORS is 75 ml per kg to be given within 4 hours, and we have to tell the community that how to prepare the ORS, and this is by demonstration method. Now if a baby is a case of severe diarrhea, because ORS is given in a mild diarrhea, if the baby is a case of severe diarrhea, in that case the IV fluid is given, and it is given total as in 100 ml per kg to be within the 3 to 6 hours, and first 30 ml per kg fast within half an hour to 1 hour depending upon the age, and the next 70 ml per kg within the next 2.5 to 5 hours. And the fluid which is preferred is either the diarrhea treatment solution or ringalactate. And if it is not available, then we can have a normal saline. But never we are using this 5% dextrose because no electrolyte is there. And the maintenance fluid what we are giving in the mild diarrhea after giving the ORS as a loading dose, then 100 ml per kg per 24 hours. In the mild diarrhea and the severe diarrhea, it is 10 to 15 ml per kg per hour. Along with this, we are adding the zinc supplementation. In a child less than 6 months, it is 10 milligram per day, and more than 6 months is 20 milligram per day to be given for 14 days. And we are giving the vaccines to prevent the diarrhea, and that is the rotavirus vaccine. And indirectly, we are giving the measles vaccine because measles complication is also a diarrhea. Then if we talk about the poliomyelitis, we know that India has eliminated the polio infection, and India has been declared a polio-free country in 2014. But still we are running our national polio elimination program, where we are giving the routine polio vaccination with both the injectable and the oral polio vaccine as per the guidelines of the national immunization schedule. And the strain in the oral is bivalent P1 and P3 after the switch day, that was the 25th of April 2016, but it is trivalent in injectable polio, that is P1, P2 and P3. Always remember that whenever we had an doubt of upcoming infection or an epidemic suspicion, we are always giving the oral polio vaccine, not the injectable polio vaccine. Along with this routine vaccination, we are having the pulse polio immunization, where twice two doses are given every year in the children of 0 to 5 year, irrespective of their vaccination. And here we are giving the OPV. And very important is we are having the acute flaccid paralysis surveillance. The point to remember here that it is between the 0 to 15 years of the age group. Any suspected individual, the stool sample is sent as per the proper guidelines. The two samples within 14 days of paralysis, 8 gram each, and collected in a container, transported in +2 to +8 degrees centigrade, should reach to the laboratory within 48 hours. We should get back the report within 4 weeks. And after sending the sample, we are giving a single dose of OPV to the susceptible children, that is the outbreak response immunization. And then, as per the report, we have to take an action. Now, indicators of the AFP surveillance, again, very important, that non-polio AFP rate reported should be more than 1 per 1 lakh, and at least more than 80% of the sample should be reported. Okay, whatever we had sent the sample, more than 80% should be reported, and we should be getting the report back. So this was about the polio infection. Now, if we talk about the cholera infection, we know that it is a father of the public health. High number of the subclinical cases and carriers are there, and this is a disease included under the international health regulation. And if we talk about the various strains, that maximum epidemics are seen with the group O, and the serogroup as group O1 and O139. And after that, that LTOR is responsible, and of the LTOR serotype, the Ogawa is responsible for cholera infection. And in the management, that we have to control the diarrhea, and the antibiotics preferred in adults is the doxy, while in the children and the pregnancy it is the azithromycin. And we have to do the disinfection of the stool vomiters with the 5% of the cresol. And for the chemoprophylaxis, we can give the tetracycline. And very important is that every 24 hours we have to do the disinfection of the water source or the well water in that particular area. Normally we are doing every 5 to 7 days. Prevention is by the vaccination and the health education. We have to educate the community that they have to wash hands, maintaining the proper disposal of the fecal matter, and cover the food, cleaning the food before intake. And we are having both the live and the killed vaccines available for the cholera, but very commonly we are using the killed vaccine, which can be either the monovalent or bivalent. Obviously, the bivalent is better. Now, if we talk about the typhoid infection, because this is considered as a disease of general sanitation index of a country, high number of the subclinical cases and carriers are seen. Man is the only reservoir. That's why the important point to remember. And if we talk about the diagnosis, the best is the blood culture, which can be positive in the first week after the infection, but it is not available everywhere. It is costly. So sometimes in the other areas, in the first week, we can go with the typhidot on the detection of IgM antibodies, because IgG, what we are detecting in the Vidal test, it is positive only in the second week of infection. Then for the cases, the drug of choice is the cefixime, and in the carriers, we are doing the cholecystectomy along with the antibiotic. Now, prevention is possible with the vaccine, and we are using both the live and kill, and the vaccine is started from the 2 years onwards. So first we are giving a shot of killed vaccine, and this effect is lasting for 3 years, and then after 5 years, then parents has to decide whether they continue with the live or the killed vaccine, because live is available in the oral capsule form, and we have to give the day 1, 3 and 5 with 3 capsules, and to be repeated every 3 years. And as per the new guidelines, if we are giving the 4 capsules on the day 1, 3, 5 and 7, we have to repeat the schedule every 5 years. Until 15 years, they say that it is adequate. Then if we talk about the hepatitis, that the fecal route of transmission is only the hepatitis A and hepatitis E. And most common hepatitis in India is hepatitis A. But if we talk about the complications, the higher number of mortality is seen if hepatitis E is seen in the pregnant lady. Now, a chronic carrier stage is seen in hepatitis B, but cancer is seen with the hepatitis C, and the chronicity is also seen with the hepatitis C. And if we talk about the uh, prevention protocol, that for hepatitis A, we had both the type of vaccines that killed and live, but commonly we are using the kill. Again, not given in our national program. We are giving separately the two doses started at 1 year and second dose after 6 months of the first dose, and this is given by intramuscular route. And if we talk about the hepatitis B prevention, then ideal dose recommended is the 3 doses killed vaccine 0, 1, and 6. But in our national program, we had a little bit modification as for our convenience. If it is the hospital delivery, we are giving the 4 doses at birth and then at 6, 10, and 14 weeks. And if it is the home delivery, then a birth dose is not given. Then we are giving only the 3 doses at 1, 2, and the 3. This 3 doses at 6, 10, and 14 weeks. Okay. Now, very important is that how we are preventing the transmission of an infection from the mother to the newborn baby. Okay. PMTCT, prevention from mother to child transmission. This depends upon the maternal infection and the infectivity. So what we do, we first go with the surface antigen in the mother as a screening, and if the surface antigen is negative, then nothing is required. But if the surface antigen is negative, or the Australia antigen is positive, or the surface antigen is positive, then we go with the envelope antigen, that is suggestive of infectivity. If the envelope antigen is also present and the surface antigen is present, in that case we are giving the vaccine and the immunoglobulin both to the newborn baby. Clear? And if only the surface antigen is present, then envelope antigen is negative, it means mother is not that infective, and only the vaccine is sufficient for the baby. Clear? So this is about your prevention of hepatitis B infection. Now, we can have the various worm infestation also in the intestine. The most common worm is Escherichiasis, but a worm causing the anemia is hookworm or Ankylostomiasis. And we should be knowing the Chandler index, that is the number of the hookworm egg per gram of the stool. And the dangerous mark is if the Chandler index is more than 300, and this is suggestive of the major public health problem. And the drug of choice for the treatment is albendazole, and prophylactically we are giving the albendazole in the age group of 1 to 19 years in our school twice a year. Okay. Then we are having the food poisoning because of the various agents, and most common food poisoning is the staphylococcus food poisoning, and the food poisoning in the fried rice is because of the bacillus cereus poisoning. The pickles or the canned food is because of the botulism. Meat or poultry products is responsible for the Clostridium perfringens, a type of food poisoning, and the milk and milk products are responsible for the staphylococcal type of food poisoning. Then if we talk about the surface infections, the one very important, although now we are not having the cases and we are still waiting for the elimination certification from the WHO, is a surface infection as trachoma. The point to remember here is that what is the drug of choice for the treatment of trachoma is azithromycin, and the dose is 20 milligram per kg of the body weight as a single dose. And the strategy commonly they ask, it is the safe and get strategy. So safe is the surgery, antibiotic, facial cleanliness, and the environmental hygiene, and the get is the global elimination of the trachoma. And here we quickly revise that we had discussed the eye strategy with the yellow fever, and we had the catch up, keep up, follow up strategy, and the arm strategy in relation to measles. So remember these strategies. Now next surface infection is the tetanus. Whenever we had roadside wounds and or the wound with the rusted any knife or sharp item, then there is a possibility of contamination of the soil having the spores. Anaerobic atmosphere, these spores will germinate and develop the tetanus bacilli, which are releasing the toxin, and this toxin is blocking the inhibitory reflux and causing the spasm. So for treatment, we have to give the penicillin as well as the antitoxin, but very important is prevention. Now, for routine as an active immunization as pre-exposure, we are giving almost the 7 doses of the tetanus vaccine, 3 as a primary DPT doses, 2 as a DPT booster, and at 10 and 16 years we are giving the TD vaccine. But very important, that is commonly asked in the examination, is the post exposure prophylaxis. So here it depends upon the type of the wound and what is the immunization status. Now if a wound is clean, of less than 6 hour duration, non penetrating, and negligible tissue damage, then it is considered as a minor category, and the rest of the wounds are the major categories. Then immunization status decides that what to do. If a person had received the booster within past 5 years, then in both the categories the no action is required. But if the booster has been received within 5 to 10 years, then a single dose of the TT vaccine is given in both the categories. But if the booster has been received more than 10 years back, the antibody titer is very low, then in the minor category only the TT vaccine is sufficient, but in the major category, TT vaccine with immunoglobulin has to be given. And if it is a non-immunized person, that for the immediate control we are giving the TT vaccine in the minor category, and will follow with the complete immunization schedule. And in the major category, for immediate management, we are giving the TT vaccine with immunoglobulin, and we are giving the complete immunization later on. So in this way we are managing the person with injury. Then a point about the neonatal tetanus, we had already declared it eliminated in 2016, and the elimination criteria is that incidence of neonatal tetanus should be less than 1 per 1000 live births. And how it was possible? It was possible because of more than 90% coverage of the antenatal cases with 2 doses of the tetanus toxoid, and more than 75% of the deliveries are the attended deliveries in the hospital by the skilled person with the use of disposable delivery kit. So this is about your surface infections. Then we had another very important group is the sexually transmitted infection, and the very important national program we are having is National AIDS Control Program. And the branch of this is, which is preventing the transmission of an infection from the parents to the child, is the PPTCT, that is prevention from parents to child transmission. Now the guideline under this is that we are having the Suraksha clinics. So remember this logo because it was asked in one exam, and these are providing the reproductive tract infection or the sexually transmitted infection or the RTI or STI services. Here we are having the syndromic approach of management, means the treatment is given based on the symptoms, not based on the diagnosis. Remember, and we are having the 7 color kits. Very commonly they ask the 3 kits, that is gray, green, and the yellow. The gray is for the urethral and anorectal discharge, the green is for the vaginal symptoms, and the yellow is for the lower abdominal pain. Then how we are detecting the cases? The cases, because here we have to detect the hidden cases also, we are performing the sentinel surveillance. So we have to do the screening of the high risk cases, and who are considered as a high risk cases are the sex workers, IV drug users, or the professional blood donors, the man having the sex with the men, or the street children, or the long distance truck drivers. Then we have to check their close contact as the contact tracing, and we have to do the checking of all the individuals moving in the same socio-sexual and the socio-economic environment, that is the cluster testing. Then if we talk about the HIV and AIDS infection, that the overall prevalence is a low 0.26%, but as we are having the high population, so absolute number of the patients are high. Incubation period is 10 years, that's why the most common age group is 30 to 35 years. And in the window period, and what is the window period is the time interval between the entry to the appearance of detectable antibodies. We have to go with the P24 antigen test, and this period is around 3 to 12 weeks duration. Then there is a possibility of transmission, and in the sexual route, that is most common, but least a transmission risk in 1 into 10,000 individuals. While parental, it is although the least common but most dangerous. Blood transfusion is having a risk of 95% transmission possibility. And in the needle prick, it is 1 is to 300. The needle sharing is 1 is to 150. And mother to child possibility of transmission is 30%, very, very high. And in the breastfeeding, it is 12 to 16%. Then another important point is that based on the CD4 count, we can have the possibility of opportunistic infections. If it is between 200 to 500, then tuberculosis, that is the most common opportunistic infection in India, candidiasis and Kaposi sarcoma. 100 to 200 is pneumocystis cerevisiae pneumonia, that is most common opportunistic infection in the world, cryptococcal meningitis or coccidioidia mycosis, or between 50 to 100, that is toxoplasmosis or the cryptosporidial diarrhea. Less than 50 is the CMV retinitis or Mycobacterium avium complex. Now, if we had detected a patient of HIV, which either we can go with the ELISA testing, confirmation is done by the Western blot test, then we have to give them the treatment. So the treatment protocol is that we have to give the drug to each and every individual now confirmed with the HIV infection. Now, earlier we were giving the medication based on the CD4 count, but now the CD4 count is not a criteria. They say all the people living with HIV should be given the heart therapy, that is a highly active ART therapy, and this is based on the fixed dose combination. And first line drugs are the TLE, that is tenofovir, lamivudine, and efavirenz. So the question is that whom we have to give the therapy to: those who had been diagnosed with the HIV, those who are living with the HIV, irrespective of the CD4 count. And this is to be given lifelong to avoid the opportunistic infection. And that's why if we are giving the antiretroviral drugs, it is increasing the lifespan of the individual, so the patients are living with HIV for a longer time. So it might increase the prevalence of the disease because the duration is more, but it is not affecting the incidence of the infection. Okay, then those individuals who had an exposure either sexually or surgically, in the post exposure prophylaxis, we are giving directly the second line drugs to be started as soon as possible within 2 hours to have a maximum results, but can be given within 72 hours, and to be given for 4 weeks, and we check antibodies after the 3 months. But very important is that how we can prevent the transmission from mother to the baby, that is PPT-CT. If a mother is a known case of HIV on the ART, we will continue the ART. This is the point what the examiner wants to ask to you, that can we give an ART in the first trimester? Yes. So it has to be continued. If mother is being diagnosed for the first time during the ANC screening, then yes, we have to start the ART as soon as possible, and we have to continue throughout the pregnancy as well as during the breastfeeding also. And in the newborn, we have to give the chemoprophylaxis, and as soon as after the delivery, preferably within the first 2 hours, we have to start. Either we can give the nevirapine. Its efficacy is less, but compliance is better. Once a day it has to be given, while the zoravirine efficacy is better, but compliance is poor. And breastfeeding, they say in the developing countries, yes, like in India, permitted, and in the developed countries, they say that we have to go with the top feed. And overall, if you can see, the prevention is by the nevirapine is 50%. So overall risk of transmission from the mother to the baby is 30%. So by nevirapine, it is reduced. A net possibility is 15%. By zoravirine, net possibility of transmission is 10%. By cesarean section, the net possibility is 15%. But if you are combining the cesarean section with nevirapine or zoravirine, then the net possibility is 5 to 7%. Now please listen carefully. This doesn't mean that we are doing the cesarean section in each and every patient of HIV. It is done only when there is obstetric indication. Now the special centers we are having, and these are the ICTC centers, integrated counseling and testing centers, located from district hospital onwards. If a person is coming there and this test is positive for HIV, patient is referred to the ART center where the first line treatment given. And if a patient is taking the drug, coming back to their hometown, and for the follow-up, they are going to the Link ART or the Link ART Plus centers. And if not responding, then going to the ART Plus centers for second line ART. Then our goal is that we have to follow the fast track, and we have to end the AIDS epidemic by 2030. And now we are having this a 95% a protocol, that earlier we had 90 protocol, but now we had 95 a protocol. Means we have to detect the 95% or 95% of the individuals having the HIV infection, and then we have to treat the 95% of the detected individuals, and those who are on treatment, the 95% should have a adequate reduction in viral load. And India also, that we have to end the AIDS epidemic by 2030. So these are a few points about the HIV infection. Now another disease that is included in the surface infection is leprosy. So the few important points what we have to remember about the leprosy is that how we are classifying and what drugs we are giving and as per the national guidelines. So if we talk about the national program, we are having the very important national program with the logo is the National Leprosy Eradication Program. And in this program we are classifying our patients based on the number of the skin lesions. If our skin lesions are up to 5, it is the paucibacillary. If it is more than 5, it is multibacillary. And now we are not using the 2 drug pack, we are using the 3 drug pack. And here the 3 drug what we are giving is the rifampicin. It is 600 milligram oral once a month supervised. Clofazimine 300 milligram oral supervised once a month, and then 50 milligram a daily orally, and Dapsone 100 milligram oral a daily. So this cycle is repeated for 6 months in POSI and for 12 months in multibacillary. Okay, so remember this treatment, and we are calling our patients of paucibacillary for the follow-up. It is once a year for 2 years and once a year for 5 years in the multibacillary leprosy cases. Then if we talk about the uh, guidelines as per the national program, that we have to um, do the elimination by 2018 as per the national health policy which was released in 2017, but the current guideline is that we have to eliminate by 2020. Okay, and this was the new elimination criteria that, as I already discussed earlier, that we had already declared this leprosy eliminated in 2005, because at that time our elimination criteria was only prevalence, overall prevalence of the country. But now we had a criteria that in each district our prevalence should be less than 1 per 10,000 and the incidence should be less than 10 per 1 lakh. Then we can say that it is eliminated, and we are still trying for that. So our goal is as per the national health policy to elimination by 2018, but our current goal is that we have to do the elimination by 2020. And we are having this Lapra vaccine under the trial, and the strain is the Mycobacterium indicus prani, MIP, and this vaccine is given along with a single dose of the rifampicin to the close contact of new cases. So this is about your various communicable diseases. Now we'll talk about various non-communicable diseases. And in the non-communicable diseases, the one very important condition is obesity. Now here we are supposed to know the various obesity indexes. The Quetelet index, the most important WHO obesity index, is weight by height in meters square. We can have the cutoff level of BMI 30 or above is considered as obese, while in the India or Asian countries it is 25 or above is considered as obese. Then we can have the Ponderal index as is used in children, that is height in centimeters by a cube root of a weight. The Broca's index is ideal weight equal to height in centimeters minus 100, and Copless index is the ratio of actual to the desired weight. If it is more than 1.2, it means the person is having obesity. Then if we are not taking weight and height in consideration, then we can go with the skin fold thickness by Harpenden skin caliper. And the most important site is the mid triceps. And if this thickness is more than 18 millimeter in male, more than 32 millimeter in the female, it is considered as obese. The waist hip ratio is more than 1 in male or more than 0.85 in the female, it is obesity. But no confusion with the waist height ratio. The waist height ratio, it is giving a risk of cardiovascular disease if it is more than 0.5. And with the obesity BMI index is more than 40, then it is a morbid obesity. So these are the important points about the obesity. Then in the cancer, we should be knowing the most common cancer overall in the world now is the what, breast cancer. Because earlier we used to see the lung cancer, but now the breast cancer is on top. But still in the male it is lung, and in India the male it is oral cancer. The female a world breast, female India breast, but in the female overall in the rural areas it is the cervix, and overall as I said it is the breast cancer. And the few important points about the cardiovascular diseases, that step approach of surveillance we are using in the non-communicable diseases. The tracking phenomena of blood pressure is that the low blood pressure in the childhood, they are having a lower blood pressure in their adulthood. The blood pressure towards a higher side in the childhood, the blood pressure is towards a higher side in the adulthood. The rule of half phenomena is also related to blood pressure. Then among another important is that Framingham heart study is a very important study. It is a prospective cohort study, and this was done for almost 20 years to know the dietary risk factors. And the diet based on this study was designed, that is called as a prudent diet, that is cardioprotective diet. Okay, so the total fat energy in Indian scenario, it is up to the 20%. And very important is the trans fats should be less than 1%. Saturated fatty acids should be less than 7%, and the unsaturated should be around 6 to 10%. Another important is national program for control of blindness and visual impairment, and the cutoff is vision less than 3 by 60 in the better eye with the best possible correction. And the most common cause of blindness in India as well as abroad is cataract. Now, what are the various categories of the blindness? That is very important, and this forms the basis of many clinical based questions. So we had a new criteria as well as the old criteria. So if the vision is between 6 by 6 to 6 by 18, then it is considered as normal vision as per the old, or we can say the grade or category 0, and normal vision or no visual impairment as new. If it is between less than 6 by 18 to 6 by 60, it is a low vision or the mild visual impairment. If it is between a less than 6 by 60 to 3 by 60, it is the economic blindness or the severe visual impairment, not the blindness, okay, as per the new guideline, because the cutoff is less than 3 by 60. Now, if a vision is less than 3 by 60 to 1 by 60, it is the social blindness or the blindness. Category 3, less than 1 by 60 to perception of light, manifest blindness, or the category 4 blindness. Or if it is less than perception of light to absence perception of light, is absolute blindness or the category 5 of blindness. So these are the various categories, and we know that we are having the vision 2020, that we have to reduce the prevalence of the preventable causes of blindness to 0.3% by 2020. And the diseases included in India is not the onchocerciasis, remember, but in place of this, the cataract, refractory errors, childhood blindness, trachoma, same as the global guideline. And in addition, we had a glaucoma, diabetic retinopathy, and corneal blindness. We are having the special infrastructures to fulfill this goal, and it is the primary vision centers, secondary and tertiary center of excellence, and apex centers. Commonly they ask their population coverage. Very simple, that remember the population of primary vision center is 50,000, just go on increasing the 10, 5 lakh for secondary, 50 lakh for the tertiary, then 5 crores for the center of excellence. And remember one more point, that we are having the ophthalmologist only from the secondary vision center onwards. We don't had any ophthalmologist in the primary vision center. That is important point. We don't had in the primary vision center the ophthalmologist, and they are present from secondary vision center onwards. And routinely we are giving a vitamin A vaccine to avoid this blindness, and indirectly we are giving the measles vaccine also, because measles in infection can cause diarrhea, can lead to the vitamin A deficiency. Then in the last we are having the few logos of the national programs, and the logo number 2 is the new logo of the National Tuberculosis Elimination Program with the slogan TB Harega Desh Jeetega. This is the logo of National Leprosy Eradication Program. This is the logo. The red ribbon is the logo of National AIDS Control Program. And if a red ribbon is around the family, it is the PPT-CT branch of National AIDS Control Program. And this is the logo. The plus sign with the central dot is the Suraksha Clinics. This is the logo of your pulse polio program, and this is your National Vector-borne Disease Control Program. Everything we had discussed while discussing the malaria or filariasis. This is the logo of National Health Mission. The most important worker is the ASHA worker. This is a National Family Welfare Program, a logo in relation to contraception. The logo of Intensified Iron Plus Initiative or Anemia Mukt Bharat. This is the logo of your Mission Indradhanush. This is the logo of Integrated Disease Surveillance Project, where the forms are filled: L form, P form, and S form in the subcenter, P in the PSC, and L form in the community health centers. Midday meal program, a logo. This is the logo of ICDS program, where the Anganwadi workers are the main worker of this centers. Then this is the logo of National Program for Control of Blindness and Visual Impairment. Then we are having the few more important activities. Just we have to know the 1 to 2 points about these activities with their logo. Indian Newborn Action Plan, and the goal is that we have to bring single digit neonatal and the stillbirth rate by 2030. Another logo is related to the healthcare of elderly, and here we are having the special centers which are giving the special care to these elderly people. Another program we are having is the national program for control of, for prevention of and control of cancer, diabetes, cardiovascular disease, and stroke. So here they say that you can see the flower is like a health. So our health is in our hands. So if we are doing our regular checkup, maintaining the lifestyle, then we can prevent these diseases. So here we are doing the screening for blood sugar and blood pressure in age group of 30 or above, and we are doing a screening of sugar and blood pressure in each and every pregnancy, also in whatever age it is. Then another program we are having is related to the National Mental Health Program. We are having the special mental clinics from the district hospital onwards, which are dealing with all the mental problems. Then another is the Ayushman Bharat or the PMJ Yojana or the PMJ scheme, and Pradhan Mantri Jan Arogya Yojana. The question was asked in the last exam that how much money is being given, and you could see that there is a 5 leaves in this, so 5 lakh rupees are being given as a support for medical care under this program. And so per family we are providing them the 5 lakh rupees per year. Another, we are having the Manrega, that is a Mahatma Gandhi Rural Employment Guaranteed Act. And here is the guideline that any person who wants the job, he has to register himself to the Gram Sabha, and within 15 days of the registration he will get a non-skilled job. Initially it was proposed for 100 days, but now it is for 150 days. Further we are planning to extend it up to the 200 days. Then we are having the 3 parallel words. One is Ujala, and Ujala is nothing but it is availability of LED bulbs at affordable cost. Ujala matlab hota hai roshni. Ujawala is human trafficking, and Ujwala, Pradhan Mantri Ujwala Yojana, it is to provide the free LPG gas cylinders. Then another program we are having in relation to the deafness, that is a national program for prevention and control of deafness, because with the aging process we are having the deafness, and that is supposed to be the second common cause of DALI. The first is depression. Now we had opening of bank accounts with a zero balance, and against this we are issuing the Rupee debit card also. This is PM Jan Dhan Yojana, and this is giving a micro insurance of 1 lakh rupees if there is an accidental death. Another is we had a Swachh Bharat mission, and the goal was that we should have the 100% scientific disposal of the solid household waste, as well as there should be the complete stoppage of open field defecation. Then we are having the Dakshita. Dakshita means training of the health workers who are delivering the MCS services. So if we are training our workers, so the good services can be given and we can reduce the maternal and child mortality. And the next is the Sabala, that is empowerment of the adolescent girl child. Then we can have this Matritva Vandana Yojana. We'd already covered the 5,000 rupees as a cash incentive for the first pregnancy and in the three installment. Then Pradhan Mantri Surakshit Matritva Abhiyan, the free antenatal care in the private sector on 9th of every month. Beti Bachao, a Beti Padhao, that to save the girl child, and we have to educate the girl child. Then we are having the Arman, advanced reduction in the mortality and morbidity in the mother and the neonate. So this is that's giving a good services to reduce the preventable mortalities. Then we are having this Kilkari app, and under this, that lady has to register from her mobile number, and she is getting the audio messages 3 to 4 every week to take care of herself, and after delivery they take care of a baby also. And we are now training the Asha on mobile, that is mobile academy. Then we are having the Laksh. Q means, here the Q is highlighted, the Q is the quality of the labor room services are improved, so reduction in the mortalities. Then there is another is the Suman. Suman is the Surakshit Matritva Ashwasan. Means every pregnant woman want an assurance from the health sector that she should deliver in a healthy baby. Means the mother will be healthy, the baby will be healthy after the delivery. Then we had another activity is Kaya Kalp, and here we are giving the incentive to the government institutions based on their cleanliness. Otherwise they are getting only the monthly salary, and they say why to work more, कोई ज़्यादा incentive तो मिलता नहीं है, private sector में तो incentive मिलता है. So now the government has started giving incentive to the government institutions, also to the staff and other employees of that area. Based on their criteria they are giving them the prices, and this is the criteria is, or the purpose is, to promote the cleanliness in the government sector or the public sector. So these are the important national programs, and one more was asked in the December exam as the urban heart. And urban heart is nothing but it is a health equity assessment response tool. Means in the urban areas we are having the strategy to identify and reduce the health inequalities. Means services should be equally available to all who are living in the urban areas. So these are the a few important national programs and their logos. Their detailed discussion we had already in the respective topics. So in this way we had quickly done the revision of a subject, community medicine, and with a special emphasis on important points. So you should be able to answer all the questions left, right, up and down related to community medicine. So I wish you all the very best for your upcoming examination.